गुड मॉर्निंग डॉक्टर फारूक।
चेहरा बदल गया।
तो कैसे हैं आप, कैसे हैं?
चल रहा है साहब कोई तरह से।
बस बस।
हाय नमस्ते सर, गुड मॉर्निंग, कैसे हैं आप?
नमस्ते भाई।
पंकज कैसे हो पंकज?
बढ़िया सर, एकदम फाइन।
और जोधपुर में कैसा वेदर है?
एकदम बढ़िया सर, अभी सर्दियां शुरू हो गई हैं, सो इट्स राजस्थान की सर्दियां। सो इट्स
वो तो
ऑलरेडी
है।
कैसे हैं सर फारूक सर, हाउ आर यू?
फाइन थैंक यू भाई। जोधपुर कैसे है?
सर
ठंड
बढ़िया।
बहुत।
सर्दियां शुरू हो गई हैं और कोविड अपना खेल खेल ही रहा है।
अच्छा अच्छा।
नमस्कार सर, नमस्कार अनमोल सर, हाउ आर यू?
फाइन सर फाइन। और डॉक्टर पंकज कैसे हो?
बढ़िया सर, एकदम फाइन।
ठीक है।
आपका एकदम एकदम लग रहा है वो शिमला वाला माहौल।
सर शिमला ठंडा है जी। डॉक्टर फारूक नमस्कार सर।
नमस्कार जी।
नमस्कार डॉक्टर भारद्वाज नमस्कार।
नमस्कार। तो फिर जुड़ गया लिंक फिर, है ना?
जुड़ गया जी फिर अल्टीमेटली।
हाँ,
घर में ही था ना आज।
ठीक है।
नमस्कार सोनू बॉस, कैसे हैं आप, हाउ आर यू?
हेलो सोनू, तो म्यूट है।
सर आप म्यूट है, सोनू सर यू आर म्यूट।
अनम्यूट करना पड़ेगा।
हेलो एवरीवन।
हेलो प्रदीप, हेलो गुड मॉर्निंग।
हाँ जी,
प्रदीप
गुड
भी
मॉर्निंग
यही
सर।
है।
गुड मॉर्निंग
सर
डॉक्टर
इंडिया
भारद्वाज।
इंडिया में ही हो।
मनोज भी यही है।
डॉक्टर सोनू।
महेंद्र सर भी यही है सर। और अगले गुड मॉर्निंग सर।
अरे महेंद्र जी भैया ग्रेट।
सोनू भी लग सकता है जी, बाहर सोनू होगा, बाहर बाकी सब इंडिया में।
ऑफिशियल अनाउंसमेंट तो पंकज सर अभी करेंगे। हमने उससे पहले ही प्री कॉन्फ्रेंस बुक कर दिया। महेंद्र सर प्री कॉन्फ्रेंस करा रहे हैं पहले।
अच्छा अच्छा।
चलिए सर।
डॉक्टर
बैक टू
सोनू।
सेशन कोऑर्डिनेटर।
हाँ जी
सोनू।
हाँ जी सर।
हाँ, यार तुमने दोबारा दोबारा बोला नहीं, कब आना?
सर आप सर आपके घर के पीछे बैठे हैं।
हाँ
आपके घर के पीछे जो लेक है ना सर,
हाँ।
वहां बैठे हैं।
बैठा सर ये
अच्छा अच्छा, वाह 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 वाह।
घूमने
हाँ
आया।
फैमिली के साथ तो जाते जाते आ जाना इधर।
हाँ सर, आऊंगा, मैं आऊंगा। अब आप आ गए ना, बस मैं आऊंगा। हाँ।
मधु मधु को लेके आओगे कब?
नहीं, मधु हमने दोनों ने बनाया है सर, हमने दोनों ने बनाया है आपको आने का।
कल परसों चौथ वीरवार तक कभी भी आ जाओ।
हाँ हाँ, नहीं नहीं नहीं, कल परसों लगाते हैं सर मधु से करके।
हाँ, बिल्कुल बिल्कुल बिल्कुल, है ना।
हाँ।
सोनू
नमस्कार
खुले
सर
आसमान के नीचे बैठा हो।
नमस्कार सर।
सोनू यार खुले आसमान के नीचे बैठा हो तू।
सर अब ये लेक का टाइम होता है संडे को एक्चुअली, तो प्रदीप ने बोल दिया कि हाँ आना है, तो मैं बोला चलो यही लेक के साथ ही करते हैं सर शरीर।
चल ठीक है। सेमिनार वेबिनार इन लेक। सर ब्रेकफास्ट भी हो रहा आपका डॉक्टर भारद्वाज, हमारे को ही कुछ दो। चल
हेलो पंकज, डॉक्टर पंकज।
हाय बॉस, हाउ आर यू, कैसे हैं आप?
हाँ जी,
इट्स
बहुत
रियली नाइस टू
बढ़िया,
सी यू।
बहुत बढ़िया, नाइस टू सी यू।
संडे, एंजॉयिंग योर संडे।
है हाँ, बस संडे ही होता है थोड़ा सा, आज धूप भी अच्छी निकली है।
हाँ नहीं बढ़िया है सर, रियली नाइस टू सी यू।
हाँ। प्रदीप भी है इसमें, प्रदीप।
प्रदीप हाँ था सर।
हेलो प्रदीप। नहीं, आज चलो उनकी ऑर्गेनाइजिंग टीम में होंगे।
प्रदीप चला गया होगा सोनू कहीं।
अच्छा अच्छा अच्छा, ठीक है सर।
पात्रो पात्रो है, पात्रो।
पात्रो
है।
है अभी।
पात्रो स्पीकर है वैसे तो।
पात्रो सर गायब ही कर दिया ना, कुछ दिख नहीं रहा।
सामने आ रहा है, सामने आपको नजर नहीं आ रहा?
अच्छा।
जैसे मैं लास्ट में हूँ, पात्रो भी लास्ट में है।
दिख गया पात्रो।
हाँ, सबसे लास्ट में मैं हूँ, सबसे लास्ट में पात्रो है।
सर लास्ट में गोल्डन पीस होता है,
लास्ट
गोल्डन।
में सर उल्टा।
वेरी गुड मॉर्निंग सर।
मॉर्निंग मॉर्निंग।
अच्छा अनमोल, हमने जनवरी में उसको बोल दिया है ना, अक्षय को।
चलो सर मैं करता हूँ बाद में आपसे, ये कर रही होगी।
वेरी गुड मॉर्निंग सर।
ओके बेटा, गुड मॉर्निंग।
कैन वी स्टार्ट दिस सेशन सर?
हाँ जी करिए प्लीज। हाँ हाँ जी।
ओके ओके सर। It's a very refreshing good morning to all the present chairpersons and the eminent speakers. Today, on this third day of the National Conference of Epidemiological Foundation of India, we have a plenary session number 7 on the topic Evidence-Based Digital Health. Sir, now I would like to introduce our chairpersons. Our first chairperson is Professor Hari Shankar Joshi, sir. He is the head of the Department of the Community Medicine, AIMS, Gorakhpur. I welcome you, sir, but unfortunately, he is not available right now because of some urgent work. Second chairperson for the session is Professor Sonu Goel, sir, Department of Community Medicine, PGI, Chandigarh. I heartily welcome you, sir. Third
Thank you.
chairperson. Third chairperson is Dr. Anmol Gupta, sir, Professor and Head of CFM GMC, Shimla. I welcome you, sir.
Thank you. Thank you.
And fourth chairperson for the session is Professor Ashok Bharadwaj, sir, who is the head of the Department of Community Medicine, RGMC, Himachal Pradesh. A warm welcome to you, sir. On the behalf of the Eficon 2020, I would like to request our chairperson to say a few words to enlighten us. Sir, please. Dr. Ashok Bharadwaj, sir, please say something to enlighten us.
Sir, you're muted. Dr. Bharadwaj.
Sir, please unmute yourself.
क्या बोलना?
Just few words to enlighten us.
Okay. So, good morning all. So this is evidence-based digital health. This is an important session for today, and perhaps it is the first session. So my co-chair, they are all learned person. They have a lot of experiences. Dr. Sonu Gol, I can introduce him. He is international personality in public health management. He is running course, and I perhaps the only person in our fraternity who has done a lot of work internationally. And otherwise, also he is associated with tobacco cessation and doing a lot of activities. His activities also planned in in the last week also. So Dr. Anmol Gupta, he's energetic person doing a lot of work in Shimla, and I can say in Himachal also. So the speakers, Dr. Faruqi, need no introduction. He is a veteran. I can say he is Vishwa Pitama. Then Ekta Gupta, perhaps she's also speaking, and my younger brother, Dr. Vinod Patro, P is there. So we will have a wonderful session, and so I will request my co-chairperson to jot down points and which we can discuss in the end, because it is an important topic, it's burning topic, and we will learn a lot from all 3-4 speakers. So thank you very much. So I initiate this session.
Thank you so much, sir. As said by the Dr. Ashok Bharadwaj, sir, Dr. Faruqi, sir, don't need any introduction. We would like to start with our speakers one by one. And starting with Dr. Faruqi, sir, I would like him to start his session on the topic epidemiological tools for containment of outbreaks of emerging diseases. Sir? Sir, unmute yourself, please, sir.
Thank you, Mr. Chairman, and all other present here. Good morning to you. So I am the opening batsman now. Now, hello, can I? Hello.
Yes, sir. Yes, sir.
I want to show my slides. I mean, that's why I think.
Yes, sir. There is option for share screen at the bottom of your.
I have done that. You cannot start screen share while others are participating in sharing.
Yes, sir. Now you can do that, sir.
Okay.
Give the
Also, sir, I would like to
Yeah,
tell that for the session duration time is 20 minutes.
20 minutes, I know.
Yes, sir. Yes.
Now, just, I mean, this is the first time I am doing on a virtual, screen. So there will be some amount of, difficulties for me. Anyway, so the theme of the plenary session is evidence-based digital health. And my topic was epidemiological tools for containment of outbreaks of emerging diseases. So I was just searching, what is the relationship with the digital. Now I found out very interestingly that there is a new area which is coming up, which is digital epidemiology. Now it's a very interesting thing that uses that were generated outside the public health system, data generated. The emphasis on the purpose of the data generated rather than on the format of the data. So the definition was made by Salate. Now I have got another definition. Digital epidemiology is the art and science of using digital technology in epidemiology. Now, what is the use of digital technology? Now, it may be for the quarantine and contact tracing, quarantine and self-isolation, screening of diseases, clinical management, planning and tracking, and medical supplies. So all these things, which includes our public health, now it can be done in the digital platform, all the records, all the data which are there. The second one, the information we require, because it is on the emerging infectious disease. So infections that have newly appeared of people population or have existed previously but are rapidly increasing as incidence in the geographical regions. Now, it has shaped the history, all these emerging infections. Now, which we can see, we shall find out the red areas where they come from, the epicenters of all the emerging diseases. One is Africa, another is China, and the other is North America and South America. Now, in India, only one disease we do, that is cholera. It is not available now. Earlier, we were the epicenters. Now, all the emerging diseases epicenters are not in India, but somewhere else. So I must pay my homage to the first person who has initiated me in preventive and social medicine. And that was on the day when I was appearing for my public health and hygiene examination in, say, 1967. Now, he initiated me and he asked me two things. What is the definition of epidemiology? I say distribution determinants of disease. So you say DDD. Now, what are the, what is the scope of epidemiology? Then we used to use mnemonics, so we said 3 E's, sir: explore, enquire, and expose. And then he said, oh, it's well done. And then I asked him, what shall I do for the after the examination? He said, you read Levin and Clark's Preventive Medicine, because then you will learn something. Now, first thing is he told me about this natural history of the disease, levels of prevention and paradigm. This paradigm is the paradigm you will have to apply in each and every practice of preventive and social medicine. Now, then I found out that these things are being utilized by the government of India in the national, in the containment of the outbreaks. I found out that all the things they're using is from this particular dynamics of COVID-19 spread in the community. Now, the first thing is that it is an imported disease, seeding. First generation cases, index cases in different district states, and then secondary cases are there. So seeding, first generation and second generation cases. Now, the next is factors influencing we should know when we start containment, the outbreak of diseases, mode of transmission, factors influencing relative risk developing infection. That is the social setting and the person concerned. One is the social setting, another is the persons who are concerned with that, and the mode of transmission. The third parameter is the timing. Now, the method which is used for this outbreak investigation is epidemiological method used is surveillance. Well, this is collection of data for action. The surveillance provides information on person, place, and time. Now, on this surveillance, what is the tool? The tool is outbreak investigation, is the contact tracing. It is an old-fashioned detective work to find each sick person, then figuring out their recently interacted. Now, this is a very important thing. It is not only collection of data. We must have in our mind a detective work, and that was initiated in me during my internship when we were doing the outbreak learning from sanitary inspectors. I mean, they are trained sanitary inspectors we had a sanitary inspector on a course, and they told me they have given me the things, hands-on training while doing the contact tracing. Now, it's a very interesting thing. Everyone knows about the contact tracing, and what I have seen now during the training program here in this COVID-19, there are very well maintained. Slides are there, and then it is given by the government of India, and it's a detailed one. Theoretically, it's okay. But unfortunately, no one has given a hands-on training. That was the most difficult part of it. Because theoretically they know, and I have seen what are the lapses there. Anyway, I'm just getting it, the contact tracing. Now this one is the behavior important to the transmission, who are the person, place, and time. You all know about it. What is the definition of contact here? Now, contact tracing was a concept that was used only for sexually transmitted diseases. At the beginning, it started with that. Now, the other things, the person to person, other than sexually transmitted disease, these are also known as a term newly has come up, proximity tracing. Proximity tracing. So the proximity, that means being within 1 meter of proximity for about a period of 15 minutes. Direct physical contact with a COVID-19. That is the person to person. Providing direct care of patients, other tailored definition, that means they are in the same area. Now, they are sharing the same environment, microenvironment. The microenvironment may be in a room, microenvironment in any of the places, whatever in our social life. So there are two terms, forward and backward tracing. This is forward tracing, that means we go to the downstream, backward tracing. So what we used to do earlier in smallpox, two groups are there. One group will do the forward tracing, another will go the backward tracing. It's a very schematically, it has been given here. You will see that primary cases are there. This is the forward tracing, and backward it would have been in the opposite direction. That means the persons who have been exposed earlier. So that was the backward and the forward. This is a very easy thing to understand. Now, the action is quarantine and daily monitoring. Now, this is the actual tool. But what is the digital technology tool used in surveillance now? There are 3, 4, 5 hats are there. That one of the thing is the contact tracing. Identify there. I have already shown you the earlier slide. Tracking, testing, contact tracing, quarantine, self-isolation, critical management. So contact tracing here identifies, track individuals who might have contact with an infected person. Digital contact tracing, what are the things? Functions. It identifies and tracks individuals who might have come into contact with an infected person. Now, technology which is used, global positioning, GPS, mobile phone, application, real-time monitoring, a mobile device, wearable technology. Now, this wearable technology is a very important thing, but which is used for the clinical but in epidemiology, that is not yet done, except for the mobile, which is GPS system. The countries which use Germany, Singapore, and Korea, but India has also started. India has also with the Arugdo Setu advantages identifies exposed individuals for testing and quarantining, track spread. Disadvantages are many. We shall be coming to that also. Now, this is the thing, Bluetooth contact tracing. Phones send out regular Bluetooth pings. That means any person who are in contact, I have learned it, I have not done it, I have learned, I have seen the students of the interns and the faculty members, they are doing it, phones and send out regular Bluetooth pings to nearby devices. The phone numbers are connected, it is made in the computer, and then they're I mean, followed up, they're tracked. Now, there are some difficulties there. One is that means there are false negatives and false positives also in Bluetooth contact tracing. Would not account for short but high risk contacts like someone coughing. If somebody is not having any symptoms, he is in contact in the proximity, but there will be no, I mean, it will not include that. Would not account for infections via contaminated surface, particularly this infection, particularly COVID-19 infection is an infection with the contaminated surface is the major area. And we have seen that in many of the places, they will say that they were not in contact, but nobody asked them about using the same toilet. Now, toilet is one of the places where we have studied, where we have seen that this particular area, we not only, I mean, use for the purpose of urination and others, but also we blow our noses and contaminate our things, contaminate the artifacts which are there. Nobody wants that social distancing is not possible there, particularly public toilets. And when we ask the questions, when there is no other contact history, but sharing the toilet, there are lots of, I mean, informations came out for that, particularly in my areas. False positive could lock contact despite the phones being separated by barriers. Now this is important, and that means in India also we have a problem with the signal irregularity. I don't know, I have not used, so I don't know what about the limitations of this, but I have asked my faculty members and the students, they say, so it's very helpful, but at the same time there are limitations. Now these are the, I mean, Bluetooth contact tracing, who has access? Under a recent proposal, that is one we know that the Google and Apple, they don't want to users' phone and never be shared with anyone. So they have got a principle that they should not give the private, I mean, information to others. Health officials, some countries like France and UK proposed where data would be collected in centralized locations. Now that no, I mean, software company, they want that they should be used. So now in India, of course, we have got India is the only country where we have a program under Arogya Setu, and that is the government in a democracy. I shall come to that. Now, what are the bottom lines? Now, the persons who have used it, they say, if you ask me whether any Bluetooth contact tracing system deployed or under development anywhere in the world is ready to replace manual contact tracing, I will say without qualification, no. The same thing with the other one, Germany, I mean Iceland. That means they are doing this. Now, Arogya Setu, the platform, which the digital platform which you use. Now, Arogya Setu means Bridge to Liberation from Disease. It's a tool in COVID context syndrome mapping in self-assessment, and it is primarily a mobile application developed by the informatics. Now, this is the only, I mean, country, India is the only democracy making its application mandatory for people to promote transparency and ensure security, and the government has also launched a bug bounty program. Now, application reached more than 100 million installation on 26th May. Amid growing privacy and security concerns, source code and application was public. Now, my question is that as I have defined digital epidemiology, it is the use of technology, digital technology in the epidemiological study of outbreaks. Now, the only tool is contact tracing. The contact tracing, now what we have done, I think, I mean, in the first half of my life in 1970s, we used to take, whenever the smallpox was there, I used to take my students and show in on-hand training. But unfortunately, after that, when there was no epidemics and other things, contact tracing, the teaching and training program remained only in the theoretical part by slides and others. Now, the students do not know And they also know the one team will go and they will do the contact tracing either by the forward contact or backward contact, and then it will be sent to the laboratory who is positive, then how to follow it up. Now this requires a technique. The technique should be learned in the field. Unfortunately, I tried to do it here, asking our faculty members. They said we cannot do it, sir, because it is monitored by the collector or the district health authority, and they have got a set line given by the government of India and from the state of Karnataka, so we cannot deviate to that. So they don't have the capability of doing it. It's not like the Central University or All India Institute of Medical Sciences, but they cannot weigh with the training program. So ultimately what happened? After about a month, the first few cases were okay. But after that, they said, sir, it is impossible to find out the contact tracing. It's a community transmission. Now, yes, there may be community, but one thing is there. I found out many defects are there because the one team will go there, ask the question. Even the question, before asking a question in contact tracing, they must know about the whole social aspects, the contact aspect of it, and their ways of behavior and others. Now there is another term, cluster testing. Cluster means what gives us a particular clue. That means if the number of cases are from a specific cluster, that means in the same business group or in the same club group or religious group, then what will happen, then you can go back, find out which are the common activities they have shared. Now this will have to study. Now here the collection is done by someone. It will go to the center, then they will study, and then yes, sometimes we get about 70, from one case, the contact tracing in the initial period in the first month, it was 60 cases from from forward and backward tracing. But as it takes a lot of time, they curtail it, they didn't do it. And the students, or the faculty members never tried to go out. That means after that complete lockdown. They also didn't dare to do it. So one thing is their contact tracing remains the same. It will remain the same. It's a detective work. It is not something else which can be learned in theory unless and until one practices it in different types of epidemiological outbreaks. And each outbreak has to be is different. Why it is different? The difference is that the natural history of the disease is different. The pre-pathogenesis period is different in different ways. In dengue, it will be different. In Ebola, it will be different. And this, COVID-19 or SARS, it will be different. So ultimately, what we have to do, we have to develop our own contact tracing methods. The methods means tools how to use it in corona, how to use it in dengue, how to use it in Ebola. So the contact tracing will be tailor-made by the public health person. There comes the knowledge of epidemiology. And there comes the question of persons who are exposed to that. I still remember my actual training was in the smallpox eradication program. One person traveling 24 hours. I was in Bihar, from Bihar to the Bangladesh border, Nepal border. In one day, we have to track it out. So it is a time consuming, it's a very, it's a very nice, it gives us rewards. That means you get a reward, satisfaction, that you can find out all the contacts spreading out everywhere. Now, with this, I want to conclude. And again, I say, whatever digital methods we take, whatever, new things we are taking, but we must have the concept first. The conceptual epidemiological concept, surveillance, and contact tracing will be there, whatever the disease may be, whatever the platform may be, but we have to deal with, in preventive and social medicine, the principles and practices of medicine as it has been defined earlier, and it remains so. Thank you.
Thank you so much, sir. Thank you, sir. Uh, now I would like to introduce our second speaker for this session. Just second speaker for the session, Dr. Pankaj Bharadwaj, sir, who is Vice Dean Research and Additional Professor at the Department of CFM and at AIIMS Jodhpur, and will speak on the topic Assessment of e-health program at HTA perspective, need of the hour. I would like, sir, to please go ahead.
Thank you, Anjali. I believe once you stop sharing your slide, I'll be able to
Yes,
share.
sir. Yes, sir.
Thank you so
Yes,
much.
sir.
So the slides are available, I believe. Just wanted to confirm from the chairpersons.
Yes, yes, we can see the slides.
That's great. Thank you so much, sir. I bring greetings from All India Institute of Medical Sciences, Jodhpur, and I would like to extend my heartfelt thanks to the organizers for giving me this opportunity to share this small work which we are doing at All India Institute of Medical Sciences at Jodhpur. So I would be taking you through the steps which AIIMS Jodhpur is taking in the field of assessment of e-health programs by the use of health technology perspective. So I'll take you to the first slide, and it says I, acknowledge the information which is there in the National Health Portal of India, which says that when we broadly speak about what e-health is all about, e-health is when we talk in terms of information and communication technology, or ICT, in health. And the very objective which is defined there, and I believe all of us will agree to that, is that whatever we do, the health outcomes should be there in terms of access, affordability, quality, lowering of disease burden, but at the same time, we should ensure that there should be a kind of efficient monitoring of health entitlements to the citizens of this country. So whether it is e-health or non-e-health, the objective still remains the same, that it should be accessible to all with a quality and with an outcome where there is an efficient monitoring which is inbuilt into the system. So now from here that the question arises, and I'll take you to my respective slides, that when all these kind of programs are launched, there is a need to evaluate the success and challenges of these IT-enabled e-health initiatives. I'll again acknowledge National Health Portal when they help us to understand that why do we need e-health? Actually, what's the need of e-health? And they say that it is actually 10 E's. If we talk about 10 E's, the first E would be efficiency. And when you say what is efficiency, we all know that efficiency is that we have to deliver that cost-effective services where there is, decreasing, where there is a decreased cost, but at the same time, we are also avoiding duplicative or unnecessary diagnostic and therapeutic interventions. Now, the question arises, how can we ensure that? And how can we ensure that with the help of e-health? We can ensure them if we, build that first slide, which I've said, information communication technology, ICT. So in enhanced communication possibilities between the healthcare establishments and through patient involvement. It also says that e-health has the capacity of enhancing quality. How can be that possible with the help of e-health? That this enhancing quality can be there if there is a comparability. And we all know that when we have different players in the health service delivery, there is always a kind of healthy competition. When there is an involvement of patient through transparency, the quality of services improved. The third very important point is evidence-based, which is the topic for me today. And that is a kind of inbuilt rigorous evaluation system, which actually give those evidences based on which we can say for surety that particular program is working well or not. Now, these empowerment of patient consumers, encouragement, education, and enabling is again through that involvement of patient into the system where we are saying that it's a kind of true partnership between the patients and the service providers. Extending beyond the geographical reach. That means when e-health is there, the services, maybe with the help of mHealth or maybe with the help of telemedicine, they go beyond their geographical domains. But there are two challenges also: ethics and equity. As my earlier speaker, Professor Farooq sir, already said, when we have these e-health systems, there are the issues related to ethics, privacy. So that needs to be ensured. And at the same time, equity. What is equity? Equity means, that at the same time, those people who do not have that computer savvy skills, they should also be able to have an access to e-health services. Now, this was about e-health, but my topic says e-health evaluation with health technology assessment. So what exactly is health technology assessment? So as we all know that HTA is a multidisciplinary decision-making process. And we do have clinicians, public health people, health economists, all in a multidisciplinary team. As we know that every system works with input, process, and output. So in a system of HT or health technology assessment, input would be in form of information which can be medical, social, economic, organizational, or ethical, related to the use of health technology. So it can be medicines, it can be about vaccines, devices, clinical interventions, or health programs. And what is the process which we are going to adopt? The process would be systematic, transparent, unbiased, and robust analysis. So in my later slides, I'll be sharing what kind of processes are usually involved in health technology assessment. And the third, which is the output, and the output again will remain formulation of a safe and effective health policy that are patient focused and seem to achieve the best value of money. So money is also a very important point. I'll take you to that slide where I say that the optimization of money is what health technology assessment also seek about. So if you ask me summarize this entire slide, I will summarize it in one line saying that HTA is a tool for evidence-based decision-making for health care benefits. So this is the slide from Health Technology Assessment India domain, which they say that the purpose of HTA would be the optimal utilization of existing resources. So whatever resources are there, we need to ensure every rupee spent is optimally utilized. And a challenge for that would be to reduce the catastrophic out-of-pocket expenditure also. And I'll take you to my work at All India Institute of Medical Sciences, Jodhpur, where we try to find out how e-health helped us in bringing down the catastrophic OOP. Health technology assessment is widely used method internationally also. And as I said, it always target, or it always have an objective that it should give an evidence that the resource allocation is optimally utilized. So if you again summarize the entire objectives of HTA, it would be on three parts: maximizing health, where it is expanding the coverage beyond boundaries, but at the same time ensuring the quality of healthcare services. The second very important point would be to reduce out-of-pocket expenditure, which we will see how it can help. And last but not the least, and I believe this is the most difficult part which we find when we were doing a kind of assessment, that how it is helping us in reducing the inequality as well as inequity, maybe in terms of gender, poverty, caste, disability, or other social exclusion, as well as the geographical barriers. So, for those who know, it is a simple slide, but for those for whom HTA is a new word, HTA says that there is a kind of comparison. And the comparison would be based on these 3-4 points. So if we have choice 1 and choice 2, we need to have a kind of comparison, and they compare about efficacy and effectiveness, value for money, social, legal, and ethical considerations, and equity and budget impact. So the most important point here would be 2 choices out of which we need to see which choice is working. But that is not just money, because when somebody says it's just about economics, no, it's not just about economics. Rather, it is a quality services provision while we are considering all aspects: social, legal, ethical, efficacy, as well as effectiveness. So the model of HTA would be like this. First, we need to have a population which is to be included. We need to see what kind of intervention we are trying to get, what is the comparator for that, what we are going to get at the end, and there is a time frame, and then setting of interest. When I share with you the work of AIMS in my later slides, I believe the things will become clearer. But the most important part is that we need to have a very specific, robust objectives, that what exactly are we going to do in our assessment. Now, this is a very interesting slide. When we were trying to develop this capacity at our institution, we tried to find out how many domains of HTA are there. And we find that there are 9 domains of HTA, or health technology assessment. The 4 they were very important, and I'll take you to that. The first one was health problem in current use of technology. The second was description and technical characteristics of the new technology. Third was safety, and fourth was clinical effectiveness. But we find that these are not just 4 domains, but there are 5 more domains which HT also says to be evaluated. The first is cost effectiveness or utility. The second was ethical analysis. The fourth one was organizational aspect. The eighth one was social aspect, and ninth was legal. To share with you, because it was our first effort in our institution, we find that if you are going to do this HTA domain analysis, it's going to be a tough job for us. And definitely, to share with you all, we find that if suppose all domains are to be covered in HTA, we call it as full HTA report, and this full HTA report covers all 9 domains. So we sat together with our team, and we find that can we do, a half of it. Then we find that literature says you can go for early 4 analysis also, and we call them as rapid review. So rapid review covers first 4 domains, and these first 4 domains are health problem in current use, description of technical characteristics, safety assessment, and clinical effectiveness. But when we sat with the team, and thanks to PGI Chandigarh also, because they are the mentors in HTA analysis, we find that there is a mini HTA questionnaire also, which covers 4 HTA domains, and that is technology, patient, organization, and economy. So we thought, why not to take a kind of mini HTA questionnaire and try to find out that whether we are able to do this analysis. So this is that how we get this, opportunity. The Health Technology Assessment India announces resource centers and technical partners. So there are currently 26 such centers in across country, and there are you can see in blue from 9 to 16. These are the blue new resource hubs. And thanks again to those who are already established, but along with All India Institute of Medical Sciences, Rishikesh, who is also the resource hub and the host of the conference today, that they are giving us this opportunity to share our work in the conference. So we took this first topic for HTA, and that was e-health. So everybody asked us, why are we taking this first topic as e-health for this health technology assessment work? The interest was because, we found that when we were having a kind of discussions, that the investment in applications in e-health are increasing very rapidly. And we also find that, e-health and digital health are said to be beneficial. But the question arises that we have to have some kind of evidence where we can say that these e-health services are actually working. But the challenge or the bottleneck, as I've written in the in the slide in the below mentioned area, that we try to find out whether we have some kind of conceptual frameworks on which we can generate a kind of assessment. And we find that because in health technology assessment, we need a kind of systematic analysis or reviews, there were very less studies which were published so far. So that took our work a bit difficult. So when we started, looking for the data, we find that only HTA reports are available, and they were heterogeneous and in terms of transparency and thoroughness. As you all know that when we are doing the systematic analysis or reviews, the most important part is a kind of homogeneous data, but unfortunately there was heterogeneous data available in the domain. The relevant assessment, as I said in HTA, they also talk about ethical, social, and organizational implications. So that kind of data was also lacking. So what we thought that whatever data is available, let us start working on that. So this was our first step. And what we did at AIIMS Jodhpur, we first took a kind of exploratory study. So we thought, why not to take Rajasthan only? Because it would be a kind of over-ambitious thing if we say that we are going to do it for the across country. So we took this initiative and we started an exploratory study to overview e-health initiative in Rajasthan. So at the time, we again discuss and we find that there is a WHO classification of digital health interventions. And we found that with the help of this classification, we would be able to classify these health interventions. So these are 4 areas actually, which we could get in this exploratory study. So there were 4 groups. So based on WHO classification, we could get them. For example, just to share with you, there is a scheme every one of us know, that is OJS. So that was in under group. So we tried to homogenize the data. Healthcare providers, we try to put them, like for example, E-Sushrut, PCTS scheme, MNGY, which everybody knows that this is E-Aushadhi in Rajasthan. So we try to put them into homogeneous, areas. So there were 13 e-health programs, and all these 13 e-health programs, we try to put them homogeneously with the help of WHO framework. Then we took the second step. The second step was we were not able to know what are the approaches, how to move ahead, because e-health programs were very less assessed across world. And in India, it's a bit a newer area. So we took a kind of scoping review, and we tried to find out what are the approaches. So through literature search, we could get 69 articles, and with all the eligibility criteria, we could find that only 15 studies could qualify for the approach. So the research which we did through scoping review, we could get around 15 approaches. I mentioned only few of them for the interest of time. So these were some of the approaches which we could get, that we could use these kind of approaches to go for HTA of e-health assessment programs. The most important point which we could get was that the literature says that it is the phase of maturity and objective of the assessment which should be considered while carrying out assessment of e-health program. So two actually approaches were of interest to us. One was benefit evaluation framework, which we call by the name of BE framework, and the second was e-health economic evaluation framework. So with all these, work or preliminary work which we did, we could get three important studies done. One was assessment and monitoring an online payment system in Rajasthan using benefit evaluation framework. The second was study feasibility and effective of ASHA software. And the third is assessment and effectiveness of biomedical equipment management and maintenance system, which is known by the name of e-Upakaran in Rajasthan. So I will share in rest of the slides my work on NHM funded study. So this was the e-Upakaran Rajasthan software, which we get a request from Ministry of Rajasthan. And they say that, can we do a kind of assessment of effectiveness of this e-Upakaran? And we were fortunate to get some fund from National Health Mission. So the objectives were two, that we need to assess the effectiveness. And as I said in my earlier slide, when we are doing an HTA, there is a kind of comparator. So we took that comparator as traditional pen paper registry system. The assessment was done on three areas: effectiveness, satisfaction levels of stakeholders, and perspective of stakeholders. So we took 10 health facilities, and it was a kind of 5 CHC, 1 DH, 4 PHCs. And the e-health system which was to be assessed was e-Upakaran. The evaluation focus was based on productivity, module usability, adoption and support mechanisms. And the design was systematic reviews, surveys, and interviews. If you can see these indicators, actually this is the benefit evaluation framework, which says about 5 important things. And this is system, information, service use, satisfaction, and net benefits. So as I said, the framework was 3. So I need to reiterate again here is that these were 3 things which we went through: systematic review, benefit evaluation framework, and third one is economic evaluation framework. So I again would like to submit here is that it was not a full HT evaluation, because full HT evaluation needs 9 domains, and it was a difficult task for us. So we took because this was our first effort, so we took only mini HTA questionnaire. So first we did a systematic review, and on this systematic review, 51 relevant articles were assessed, and we could find out that this review suggests that there is an improvement of information quality, use, and net benefit. But at the same time, it also talked about bottlenecks, and these bottlenecks were that if the user is not having the sufficient skills and training, there would be difficulty in the use of this software. This was a clip of the few of the articles which we could get in the systematic review. The second very important part was this benefit evaluation framework. Success of any e-health program, it depends upon adoption of 3 important things. Number 1 is the quality of information. So this first block is about quality of information. So that is very important. But the second thing is, when we say about this, it is about usage and user satisfaction. So that is something which is important, number 2. And the third one is net benefits. And when we say net benefits, it is in terms of quality, access, and productivity. So our team thought of why not to go for all the 3 things. Number 1, because it's a benefit evaluation framework, that number one, we should talk about the quality of information, user satisfaction, and net benefits. So system quality we assessed, and I will take you to number 3 dot, which you can get. We find that there is an improved mean time to repair, because we were talking in terms of it's a management equipment system. Actually, it's e-upakaran. So upkarans are to be managed online. So we tried to find out where there is an improved mean time to repair, and we could get that. For example, ECG mean time reduced by 2.6 times and X-rays by 2.5 times. So there was also a protection of the integrity and use of data by means of providing authorized access. Information quality was also better. So we could find out that there is an information quality through, with the help of e-upakaran, there is an accessibility and availability of detailed report. We all know, usually we all worked in management, we all are there in sometimes hospital information system, hospital management. There is a problem of accessibility and availability of detailed reports. So we could find out that that was available through that. So these are some of the machines which we took in our analysis, and you could see that there is a huge improvement. Then there was an end user satisfaction we talked about, and the end user satisfaction was based on content, accuracy, format, ease of use, and timeliness. So you can see here that there is a utilization coefficient which is increased by more than 50%. So e-upakaran has improved the utilization of all biomedical equipment, utilization coefficient more than 50%. And usually all of the users, they strongly agreed to the fact that the desired information is available most of the time through e-upakaran system. So you can see that the utilization coefficient of most of the machines is improving. What were the net benefits? I'll take you to this in the interest of time. This is operational equipment effectiveness, OEE. So you can see that OEE for critical equipment, like for example, ECG, X-ray machines, and sonography, that increased respectively. So that is an important point, because I said net benefit in terms of quality, access, and productivity. So you can see that operational equipment effectiveness of the machines was increasing. Uptake time. So this is an important slide. So if you can see the uptake time of most of the machine, you can see this is the e-upakaran and this is before e-upakaran. You can see improvement in most of the uptaking of all these machines. So I'm taking you to the last slides, and that is about economic evaluations. So that was the third area, as I said. The systematic evaluation was the first. The second was benefit evaluation, evaluation network, and the third one is economic evaluation. So in economic evaluation, you could see there is a cost of service ratio, and cost of service ratio is a useful measure in determining the financial effectiveness of a maintenance system. So we could find that cost of service ratio of e-upakaran was 1.9%. So just to share with you is, there is a benchmark that if cost to effective ratio is less than 2%, it is said to be outstanding. And if it is less than 5%, it is said to be good. So we could find out that there is an outstanding cost of service ratio of e-upakaran. My last part, because I said the out-of-pocket expenditure was an important part, which Government of India says that when we are evaluating these services, so you can see that when the equipment failures are less, so when equipment failures are less, the patients are going to use this equipment in the public health facilities only. So when the equipment failure were less because of upakaran, so we could find that this is the safe. So out of pocket health expenditure saved. You can see ECG machine 50,610. So you can see the X-ray machine. So most of the time they are actually not working in order. But when e-upakaran was there, we could find out that they can be improved very early, because there was a responsiveness. So you can see that out-of-pocket expenditure were also reduced. This is my last slide concluding. And with all these HTA framework, we could find out, that these system is working. But as I said, with all these steps, the challenges which we faced while doing the kind of evaluation of e-health services, these are the two recommendations we thought of at the time, is that there is a need of standardization and staffed approach for reporting characteristic of these e-health services. And we need to specify and we need to work more on the assessment of outcomes and methods. So, and that is when we can standardize these method of assessment, we would be able to ensure the quality and comparability of e-HTA assessment. Thank you so much, and sorry for taking a bit more of time. Over to Chair. Thank you so much, sir.
Thank you so much, sir, for this interesting and informative talk on this topic. Now, introducing our third speaker for the session is Dr. Ekta Gupta ma'am, who is professor and head of the Department of the Clinical Pathology at the Institute of IILB, Liver and Biliary Sciences, New Delhi, who will be speaking on the topic blood-borne viruses and healthcare worker safety or evidence-based NSI management. I welcome you, ma'am.
Good morning to everyone. Can I share the screen?
Yes,
So
ma'am.
first of all, I must thank the organizers for fitting a real odd one out person from this conference, and I definitely after the two, I must congratulate Dr. Bharadwaj for his excellent talk, and I was like very impressed with it. Although it's my talk has nothing to do with any e-digital or this public health approach, but it is a very important problem which I felt and we healthcare workers are dealing with. So I'm also looking after, so virology goes hand in hand with the public health programs. As you know, the earlier speaker also mentioned how viral outbreaks are contained, and e-health and this digital technology can definitely help and improve so many viral infections and outbreaks. So I'm not a public health person, I must say, and I must excuse. So we would be just talking about a very, very important, but it is a very small topic. And looking at how the scare of the viral infections are there, what is the importance of the health of the healthcare workers to us, and how our institute, and probably if with these technology, your programs, you can improvise on the healthcare workers' safety and those issues also, that would be an excellent work to go hand in hand with the public health using these technology and management. So my talk would be very short because I know you are not a microbiologist, and this is basically focusing the microbiologist. I'll be just talking about that this is a very important aspect since we are all healthcare workers. I could have taken a talk on COVID-19, but there's so much of literature available, and we all know very nice algorithms, very nice management protocols are there. This is one important topic which I think we are from our MD days, we've been taught about it, we're hearing, but does each institute is doing enough to ensure that these bloodborne viruses are taken care? So just to tell you, this is nothing new that we are all exposed. So apart from the respiratory illnesses, which we are going through a pandemic, there are three important bloodborne viruses to which all healthcare workers are exposed, and there is a risk of transmission. Bloodborne viruses and healthcare workers, they are a dual-edged sword because we can get infections from them and we can also transmit. And I come from an institute which is of immunocompromised like liver and biliary sciences, where all the transplant recipients are there and all those with the liver disease, severely cirrhotics, so they become immunocompromised. So taking care of these infections is very, very important. So you all know the risk of transmission ranges depending upon the virus to virus, and hepatitis B virus poses more risk of transmission as compared to hepatitis C and HIV. So like dividing the problem, like it can be pre-exposure. So it's more of a, I'm just going to share very little what we did, but I'm just thought that let me revise some literature with all of you public health experts so that it is a revision class more. So pre-exposure, exposure, and post-exposure. pre-exposure comes the immunization and vaccination of healthcare workers. During exposure, all the steps that we take of universal work precautions and waste management, which again requires institutional programs and all the algorithms to be in place so that the healthcare worker safety is ensured. Post-exposure requires a stepwise management and monitoring, which again requires a lot of programming and institutional commitment so that such infections can be taken care. Now, there are a lot of literature, there are a lot of things about the vaccination, although we have hepatitis B annual immunization program, and the adult immunization is there included in it, but still what is the status? You will be surprised to see that lots of people have done the studies and the immunization to hepatitis B. Now, there is vaccination and immunization. So vaccination is that when you receive the complete dose and when you achieve the sufficient antibody titers, then it is an immunization. You'll be surprised to see it's still not 100%. It's still not 100%. And we have to tackle this problem. We are talking about COVID vaccines and the healthcare workers, but these are the other problems, neglected problems. We've still, despite being a very good vaccine available, we have not attained 100% status of all the healthcare workers who are working. So what we did is that, yes, as being told that whenever there is a problem, there is a lot of literature available. You can work upon the other person's literature, but you should also start doing. So at the very beginning, like our institute is about 12 years old. So at the very beginning, we also tried to have an awareness and, what is the coverage, what are we lacking? So you will see that despite, so it is the healthcare workers, is not only doctors and nurses, and they come to close to about 80 to 90% vaccination. It is the other healthcare worker, that is the technical, the non-technical, other staff who is more involved in exposures to such viruses. So that is lacking. So when you're talking about evidence-based technology, and when you're talking about such thing that where you should focus. So again and again, stepwise, introduction of any institutional policy should be done, and it should be first given to those who are actually needing it, rather than making an institutional policy and just starting with the doctors. So we felt that it is the technicians and the other technical, non-technical staff. We also tried to look at their attitude and practices, and we found that they are grossly inadequately aware about, and their practices and attitude was also not sufficient. For the doctors, it was always there. So that is why we felt like 12 years back that there is, despite you have a national policy, you have state-wise policies, but still you require individual institutional policy, especially in the government sector, so that you can have the vaccination protocol done. Now, just to recap, there are a lot of unawareness about the hepatitis B vaccination. It's a very good vaccine. We give 3 doses of it. The anti-HBs titer, it is done to know that whether we have responded to the vaccination. So I said that vaccination means administration, but whether our body responds to this vaccination by generating a very good immune response is known as immunization. So the thing is not to have the tick boxes done that we have got the vaccine. Our ultimate aim is that we should know that the person is immunized or not. So by doing an antibody titer, you have to assess that it is there. And then you require a documented proof. So you should have your healthcare workers documented proof that whether they have received all the 3 doses or not. So we made this policy, and this is the CDC's protocol also, that whenever anybody who has come, so at our institute, there is a policy going on at the time of the joining only. We give them a form to fill up. They fill up whether they are totally vaccinated or they are not vaccinated. If they have complete 3 vaccination doses and a documented proof that they have responded, by demonstrating to us more than 10 million international units titer, then we do not do anything. But if we think that they have not got it done, so we can at the time of joining, we do an anti-HBs titer, then we follow the whole schedule as mentioned in the literature, and then we try to give booster, either single dose or give 2 more doses, and try to maintain the healthcare workers antibody titer to more than 10. 10 is considered as protective enough. But then the healthcare workers who are involved in a lot of handling of the blood samples, like the technical staff and who's handling BNC infected samples, blood samples, there are a lot of literature which is available that more than 100 million international, if it is done, then that gives a very good immune boost response. So we try to keep it more than 100, although the guidelines say it has to be 10. Now, in case the person does not know that whether they have completed the vaccine or they have got just 1 dose, this is very often a problem, like they have interrupted schedules. So we do not restart. We do not just forgot that they have taken a vaccine earlier and start the 3 doses again. You just try to understand whether they have taken 1 dose or 2 dose, and try to complete that previous vaccination by giving the 2nd and the 3rd dose. And the ultimate aim is that they should have more than 10 titer. Now, 3 doses is important for healthcare workers. This is, we have found, and there are a lot of literature available, that if you have not received 3 doses and still your anti-HBs titer comes out to be more than 10, then that is not a strong, robust immunological response, and you might not be that well protected. So you have to have complete 3 doses completed and then go and get an anti-HBs titer done to check it. Now, needle stick injury, I think it's like everybody knows, it is when we are working. So that was the pre-exposure. So during exposure, we can get exposed to these blood-borne viruses. Again, there are a lot of papers, there are a lot of literature available, but still you'll see the incidence of needle stick injury, which is reported, is quite high, like 80% from a new published Safdarjung paper from New Delhi, and quite high. So we again, evidence-based, we try to find out over the last 10 years what is our needle stick injury record, and we did see that there were 103 reported incidents. So we have a very well documented hepatitis B vaccination policy placed in our institute, and management of these needle stick injury exposure and follow-up of patients. And despite that, we could see that there was a high risk exposure which was there to hepatitis B, C, and HIV in our healthcare workers. Now, we try to see the reason, and you all know there is a lot of published literature that recapping and improper segregation and disposal of sharp is the most common reason. So this, since we knew this was a problem in our institute, we started focusing on what to do, and we have implemented, in fact, in our OPDs, not to use safe injection devices, which are reuse prevention syringes. So although it costs the cost of a normal syringe and reuse prevention syringe, there is a lot of cost difference, but we have implemented it, especially all those places wherever the blood has been collected, and we have ensured that this recapping is not done. So this is like what our own small institute data we generated. Regarding the improper segregation of sharps, we continue taking the classes, informing them. We have made a very good infection control team who are again and again ensuring that such things are not happening. You have to develop, evidence that what is the problematic area in your institute where such incidents are happening and why they are happening. So you have to collect the evidence. Like in our institute, we found that mostly from the wards it was coming. And so we started focusing all our attention and, all our awareness campaign towards these sites. And although despite all these 103 were high risk exposures, we could manage all of them, and none of them actually seroconverted, and we could manage them very successfully with our very robust institutional policy in place for the management of such exposures. We also time to time try collecting, and I was really impressed with the previous speakers, e-health technology and digitalization of all these things. This is totally a manual record. Most of the microbiology, I'm sure, in your institutes are also collecting such information, but we normally do not have such devices, such system by which know the reasons that the healthcare workers are not reporting, and whenever they are flaunting any waste, improper waste thing. So such alarms and such systems should come. So that can be a good help if the public health people can just discuss with their microbiologists and their institutes and try to find out that what alarm systems, what check systems we can put in place in your own institute so that such incidences are reported properly, immediately, and they're not repeated again and again. So what we found interesting was that in our institute, that there was a strong belief that if you are vaccinated for hepatitis B, so that is sufficient enough to protect you, and they were not coming and reporting. And this is again, it is coming out very true when we are seeing that for the COVID vaccine also, that people think that that vaccination will help us prevent that viral infection, and there will not there will be no need of social distancing and mask wearing and all. So such beliefs need to be countered. We went and we started taking classes that which group is adhering to such knowledges. So first you always do cap study and then try to find try to take action over these deficiencies, and we try to tell them that it is not so. It will only protect you from hepatitis B, but there is HIV, there is hepatitis C for which there is no prevention, and you really have to take care of all those things. So you cannot do that, I am vaccinated, I'm immunized, because earlier our focus was more on hepatitis B vaccination and immune status. So we thought that about hepatitis C also we need to educate them. So these are the important, why I wanted to show you this slide is that these are important measures that you need to take in generating evidence-based, practical guidelines and algorithms for healthcare workers, because you need to know what are the deficiencies in them, and you need to focus how to overcome these things. So I'm not going into detail of why, because it's all known that it is the body fluid, the type of the injury which happens, and there is a whole algorithm and steps which are involved in taking care of if the needle stick injury happens. So I'm just going to just tell you briefly that you should have in your institute, and I'm sure most of the institute has got the proper exposure, post-exposure management, and it should be documented, it should be taken care, it should be reported, and the complete lab evaluation and monitoring of the healthcare worker needs to be done. These are the different kind of exposures that we define, what is known as a mild exposure, moderate exposure, and severe exposure. In case, so the HIV imposes the greatest, threat. Now, B, you have a very good vaccine, so you can have your all your healthcare worker immunized. For HIV, certain amount of threat is always there, because you need to start, because that is a virus which will go and will give you a lifelong infection and does not get removed from the body because it integrates with the host cell, just like hepatitis C. So you have to take care of HIV and HCV. And so the post-exposure prophylaxis, it should be available, it should be immediately started. In case of hepatitis B, you don't have to do anything. There is the entire algorithmic approach which is mentioned, it is given. You just really need that these things, these check boxes, these forms, they are available with the person who is going to manage. And it has to be done on the evidence-based and the algorithms which are placed, not just like do this, do that. So you have to have a very stepwise management of these post-exposure prophylaxis. You should know what is the source, what is the status of the exposure, what you're going to do. So the immunoglobulin has to be available in your institute, the proper vaccination doses should be available, and you need a dedicated microbiologist to take care of all these policies in your institute. Hepatitis C is often we are not aware what to do, although you do not have any role of any antivirals into it, but the monitoring of the healthcare worker who gets exposed to hepatitis C infected patient is very, very important, because you need to monitor, you have to get when to get an RNA done, when to get an antibody done, and in case the liver function test gets deranged, when to start the proper antiviral. So you need the systematic stepwise monitoring of the healthcare workers for hepatitis C management. The monitoring of the exposed, again, this requires algorithms, and it is just not that you just tell them, okay, go and we will do it later. You really have, so you should have such alarms, such systems which are there. And with the COVID, we have learned so much of the usage of these e-technology. So these kind of alarm systems should be there. So the healthcare worker is, very often we find this problem that we are trying to contact the healthcare worker from the microbiology lab that please come and get your repeat HbSAg, HCV or whatever test done in the lab, and they do not come. So such alarm systems should be there, so that it beeps on their, gives messages, WhatsApp reminder to their phone, so that they know that yes, I had suffered this and now I have taken a vaccine, so I have to go and get an anti-HBs titer done, or I have to recheck my HCV antibody status done. So such the e-technology, the digital technology can help us actually in management and monitoring of the infections. In prevention, again, this is just last few slides which I like to share, is that the training and is very, very important in preventing such thing. So you should have proper training of the healthcare workers, what to be done, how to be done, and you should have an institutional policy placed in your institute, which is followed. So I'll just like to summarize here, and then few words about if the healthcare workers are infected, if the time permits. The healthcare workers should be aware of these bloodborne viruses. And since we do not have the national guidelines, this is one sector which is lacking for healthcare workers. So you should have, we have got a national hepatitis program which has come up in 2018, but so much of stress on the post-exposure management of these viruses for healthcare workers is not given into it. And so we should develop our own institutional guidelines and SOPs so that we can manage. So this is what we have done in our institute. We have made a dedicated website, and all the algorithms and are there on this website. If a healthcare worker finds, they just have to log in, put in their details, the alarm system comes to us, and we are able to follow them up and take care of their needle stick injury management. So here in a very brief presentation, because I know it is a public health meeting, but such issues are important to be discussed and brought into the daylight, so that each institute uses these digital technology and can take care of these systems. I thank you all once again. Thank you so much.
Thank you so much, ma'am, for this knowledge. Now, I would like to introduce our fourth speaker for the session, Dr. Binod Kumar Patro, sir. He is additional superintendent at AIIMS Bhubaneswar, Associate Dean Research, AIIMS Bhubaneswar, and also additional professor in the Department of CFM at AIIMS Bhubaneswar. He'll be talking on the topic Digital Divide in Health Management Information System in India. May I request, sir, to please proceed?
Thank you, Anjali. Thank you, the chairpersons. I will be the last speaker in the panel, and it is always a pleasure to listen both Dr. Ashok Bharadwaj, Pankaj Bharadwaj, and Dr. Farooq has been our teacher, and Ekta Gupta, madam. So I'll be the last speaker, so I have certain advantages. So let me share my slides. My slides are visible. Can anyone confirm my slides are visible?
Yes, Vinod.
And am I audible, sir?
Yes.
Audible.
Okay. So thank you very much. And I have next 10 minutes with me. I will, for the interest of time, I will quickly finish. The digital divide in health management information system in India. What dividends, what Dr. Pankaj has talked about, I will be looking at a bigger picture. This particular thing which bothers all of us in our when we work in public health system, the health management information system is one of the important decision making or interesting tool which will be useful for efficient delivery of efficient health system. So this will be my outline of presentation. I'll be talking something about the building blocks of health management information system, HMIS in India, newer initiative. What are the key challenges in India? So this talks about in 2005, the theme paper published in the World Bulletin of World Health Organization, which talks about health information system is the foundation for public health. Without an information system, we cannot think of providing equity-based public health delivery system. So there are challenges of harmonization, technology, complex health system, and health system across the world is also too much complex than any other system, whether it is respiratory system, cardiovascular system, all systems will fail at the complexity of health system. So these are some data needs at different level. If you look at communities at the bottom of the pyramid and global data and the the decision making strategies are different. At global level, they are more strategic, but at a bottom of the pyramid, they are more of operational. The data needs will be utilized for operational needs at the bottom of the pyramid, and at the top of the pyramid, it will be more strategic. What are the types of tools we use is usually surveys, that annual health surveys or any periodic health surveys we do at communities. At facilities, we look at outpatient, emergency, then surveillance data, then we look at birth and death registries. Then service and district level, we map out health services, administrative data, surveillance. Then at country level, we have vital statistics, vital registration, census, national household or national health surveys. And at global and regional level, we have modeling and estimates. So when you look at the information system, it has two key purposes. It ranges from operational, it addresses operational issues. It directs strategic instructions for efficient health services. These are some of the sources which I have talked about, but the bottom of the sources are usually annual health survey, which is being done by people who are paramedical health workers or frontline health workers. And at top of and we have something decennial census, which anchors around, and we have different types of data which comes from different sources. There is a need for integration. This is something where health HMIS in India, a typical district hospital data looks like this. A person is bowed with too much of cluttering of data and he is clueless where to go ahead. But things are improving. We are not, this scenario used to be there, but still continues to be in difficult districts in India. It remains like this. This is what the digital divide, the country is going ahead with National Digital Health Mission. How do we go ahead with this? There are some solutions. The solutions are electronic medical record and electronic health record. Medical record predominantly looks at hospital-based data. Health record looks at system-based data, which are digitalized, archived, and analyzed for decision making. In 21st century, India was a digital republic, and its rise to IT power was published. And if you see the number of internet users, mobile penetration, smartphone users, there are electronic bank accounts. India is globally number 2, just behind China, and it is going to cross in some times, as we say. The move is in a positive direction. Technology has penetrated through urban-rural. It has bridged the urban-rural divide. It has bridged the education divide. People not too much educated also have started using technology for their day-to-day practice. Existing, when we talk about HMIS, this is hospital management system and health management system. So the hospitals which are in a corporate or private sector who are fully computerized, a few successful examples are Amrita Institute of Medical Sciences is a super specialty hospital, caters to 50 and more specialty services, is completely computerized. LV Prasad Eye Institute is again a multi-specialty eye institute, and it's fully computerized. The current evidence says which are specialty hospitals are purely computerized, and one specialty like eye specialty, oncology, this one group of hospitals which cater to one specific disease or one specific system is easy to integrate, easy to computerize. And however, Amrita is a multi-specialty hospital. Max and other hospitals are also fully computerized. The story in public sector is also equally rewarding. If you see, e-Nikshay is a fully IT based. Dr. Asok Bharadwaj has talked about e-Nikshay is a national tuberculosis elimination program. The HMIS is a successful program. National Teleconsultation Services e-Sanjeevani, which has picked up during COVID times, was a successful model. E-Raktkosh is the blood bank program, which is based on Umang software, and it is also completely successful. NHM HMIS is also a successful model. We have fragmented HMIS, program-based HMIS, which are there in bits and pieces across system, which there is a challenge to be integrated. So there is something which has started in the last 2 years, integrated health information platform, which talks about 33 diseases. 33 diseases are taken, 33 programs and diseases of epidemiological potential of pandemic or outbreaks have been taken into integrated health information platform, which works under IDSP. So the initial rewards has to be converted into a strategic positioning so that we are at we get the dividends of digital India. So there are some evaluations which have been done, which are in the primary healthcare system. Evaluation of a management information system for primary healthcare in rural India, which is from Haryana, Vallabhgarh, which says that there was saving in time, and the cost is beneficial. The initial costs were high, but the recurrent cost is low. So that there are efficient health management information system which are there in systems which are in primary healthcare, which have been functioning for quite some time. Similarly, one of the system evaluation was done, quality of health management information of RCH, maternal and child health services in Haryana, which was again done in Haryana, which says that HMI's records for MCH services at sub-center level of Haryana were satisfactory in terms of completeness. And there was a significant difference in terms of reported and evaluated coverage. So the coverage issues were there, but largely they were in similar direction. So with this background, the Union of India has started National Digital Health Mission, which has six components, which are at this point of time, which has envisaged health ID card or identification card for every individual, telemedicine, DigiDoctor, health family register. So what we have been doing in family registers will be digitalized, personal health record, which is predominantly a medical record, and e-pharmacy. So this is what the Union of India is looking at, which has put its blueprint in the public domain for comments. And I'm surprised to, I was very surprised to see only 77 comments they got from a billion population country. So who are the stakeholders? When we look at stakeholders for this digital health mission, we as a public health professionals were on one of the stakeholders as this is being planned to roll out for the whole country. So healthcare professionals, providers, third party, policymakers, administrators, and third sector, NGOs, associations. So we fall here in the third sector, that is associations. How do we translate this National Digital Health Mission for public health decision making? What are the principles of the tagline is think big, start small, and scale fast, which is important for this newer initiative, which is likely to, I am sure it is going to scale fast, and it is going to replace the age-old paper-based HMIS, which has been there. And the current HMIS, they say it is a hybrid model. It has some components in paper, some components in the digital archive. So what are the principles of National Digital Health Mission? There are domain principle, that is health domain, and technology principle. So the technology principle is minimalistic design. The design is we start with small, and it has to be interoperable so that it accommodates the existing HMIs which are there, and open APIs which are open free source APIs where will be into build. But however, in the health domain, it says educate, empower, universal, inclusive, and accountability and national portability has to be there. So the whole idea is it will be useful if we move from paper-based or hybrid model to fully a digitalized health model. Then we're likely to achieve universal health coverage, what is envisaged in National Health Policy 2017. So the key challenges is infrastructure issues. At this point of time, when we looked at in our operational area, there are infrastructural issues like although we are positioned in the state capital, the issues of electricity, issues of hardware issues, IT infrastructure issues were still bother the health system. Health technology manpower, whether are we going to skill enhancement of the frontline health workers, because they are going to the data generators. If their skill is not enhanced, the data what we will be getting has to be taken with a pinch of salt. Coverage issues, are we this digital health mission is going to, because our 50%, 60% of our clinical care is from private sector. Is there going to be a harmony between private sector and public sector? Digital health mission is currently focusing on the public sector and insurance based schemes. Through Ayushman Bharat, private sector is also going to be roped in for this digital health mission. Harmonization of existing programs based HMIS. This is that IT counterpart will be taking care. They will be looking at the existing all HMIS will be pulled into the digital health mission. Transition from traditional HMIS to digital health HMIS is going to be jerky, going to be time consuming, and there will be resistance by the health manpower. So the most important is whether the current manpower who are working in the conventional health system will be able to accept the digital the transformation to digital mode. So what's the solution? At All India Institute of Medical Sciences, New Delhi, they have started with a cadre of nurse informatics. So these are the people who are from nursing background. They are given a training of informatics, and they handle the health hospital management information system in one of the centers of AIMS, that is Jayaprakash Narayan Trauma Center, which was awarded and rewarded. So I close my presentation with this. As a public health team, we need to think big and scale fast, start small and scale fast. How do we contribute as an association for this national digital health mission? Will be useful for this change? Change is always faced with the resistance, and as an association, we should support the change which is envisaged under National Digital Health Mission. Thank you very much.
Thank you so much, sir, for this informative information on the topic, evidence-based digital health. Now, sir, I would request our respected chairpersons to have an open discussion with our speakers for just short of time, if anybody wants, sir.
So I thank all the speakers. Dr. Faruqi, he brought he shared his experiences right from internship to the position he's holding now. He focused his attention to COVID. So it was a wonderful discussion. Then Pankaj Bharadwaj, he's always a younger brother to me. He has done studies. So it was very nice to hear his finding, his observation in that study in youth, because youth, Rajasthan is doing a marvelous job as far as HTA they are concerned. So I was also attached with now National Institute of Implementation Research in NCDs at Jodhpur. So then Dr. Ekta Gupta, she brought her experiences of by Liver Institute in Delhi and deliberated in details regarding the various issues, and which I found interesting was the exposure prophylaxis. Then Dr. Patro, so he also explained in details how these digital technologies can be utilized. When I was Tanda, we had used this technology for tuberculosis as well as for diabetes, diet management, and Dr. Anmol used for contacting a patient on tuberculosis. So I will not take much time. I will ask Dr. Sonu Goel to say a few words, then Dr. Anmol Gupta to conclude. Dr. Sonu.
So, yeah, thank you, Dr. Bharadwaj. Thank you, sir. So I think Dr. Bharadwaj has very aptly summarized what was there by the four presenters and very nicely presented the aspect of digital health, which has gained momentum in these COVID times. Like we had been doing something digitally over a period of last decade or so, but I think as far the presentations goes, like Dr. Pankaj told about STA and how it was useful, and then Dr. Faruqi told about the experiences. So I think it has gained momentum in these COVID times, and you all will agree that all these, even the teaching, there has been a reform which was not there before. But after COVID, I think this digital thing has bring reforms in teaching. Although there are some negative aspects of it, everybody agrees to it. But there are many positive aspects of teaching online. And now this conference is going on online, and many people can sit at their home on Sundays having their lunch or breakfast and then like listening to the lectures, wonderful lectures by the experts. So I think this is the best part of that digital thing. So congratulations to all the speakers. I think they did wonderfully well. Dr. Patro, I think, explained about what is the digital divide, which is now now happening after this reform has been there. And Dr. Faruqi, Dr. Pankaj, and Dr. Ekta. I think she said that it was different, but I think that brings a spice in the presentation or the group of presentations which were there. So I think I don't want to say further words, and I hand over it to Dr. Anmol for. If there are any questions?
Can I speak? I'm extremely sorry. I could not share my presentation. It was very much there. Nobody informed me. I mean, I'm feeling slightly.
You were quite clear. You were quite clear during the presentation. So I think no issues. You can share it with these organizers, and they can share it with the participants.
Yeah, sure. I'm feeling this is the lack of
the necessity of seeing the presentation. We did not feel the necessity because it was so clear.
Done.
So thank you.
Thank you so much, sir and ma'am. Ma'am, we are very sorry if for your slides. You can share with us, ma'am.
Can I say something?
Yes, sir. Yes, sir.
Are you listening me?
Yes, sir. Yes,
So,
sir.
at the outset, I am thankful to the team Eficon 2020 and the organizers, especially Dr. Vinod Sarwastava, who is the organizing chairperson, Dr. Umesh Kapil, Professor Ravi Khan, Director AIMS, Professor Beena Ravi, organizing secretary, and Dr. Pradeep Agarwal, co-organizing secretary, for giving me opportunity to chair this very important and relevant session, evidence-based digital health. It was great opportunity to listen from eminent speakers, Dr. Farooq Ahmed, Dr. Pankaj Bharadwaj, Dr. Ekta Gupta, and my own friend, Dr. Vinod Patru. I would like to supplement few comments. Dr. Farooq Ahmed told about the relevance of contact tracing, isolation, quarantine, social distancing, risk factor in identifications, and some of the epidemiological tools which can be used in the different emerging diseases like COVID-19, Ebola virus.
Dr. Anmol, you are muted.
Okay, I think we are done with the current session, and the next speakers are in line. So I am extremely thankful to the chairpersons of the speaker. Anmol sir, are you there?
Yeah.
Sir, if you can just wrap up in another minute.
Yeah, but my sincere thanks to all the speakers as well as to the chairpersons. Thank you.
Thank you, sir. Thank you. Thank you, sir, for your remarks, sir. Okay, now we are heading with the next session, sir. Back to the coordinators.
Good morning, everyone. I'm audible to everyone. Right. Could I start? Good morning, respected chairperson, speakers, and delegates. A warm welcome to everyone from the team Eficon 2020. Uh, Now introduce chairperson Dr. Siddharth Ansushar. He is the additional professor in Department of Community and Family Medicine, Jipmar Pondicherry. Dr. Dibat Roy, he is a professor in GMC Dehradun. Dr. Manish Kumar Goyal is a professor from Lady Haden Medical College. We have we have three speakers for the today event for the non-communicable DE session. Dr. Rakesh Kakkar, sir, he is the head of Department of Community and Family Medicine, AIMS Vijayawada. Dr. Aviruchi ma'am, additional professor from AIMS Raipur, and Dr. Umesh Kapil, sir, from LVS New Delhi. So finally, we are going to our session. I request Dr. Professor Rakesh Kakkar, sir, kindly start your presentation. On the topic? On the topic.
We can see your slides, sir. Go ahead.
Thank you thank you organizers. I would like to thank all the organizers for giving me the opportunity to present this important discussion on outbreak. So media has highlighted it too much, and though it was a cause of concern also, but it got a lot of attention. So this Eluru is around 58 kilometer northeast of Vijayawada in Andhra Pradesh in the West Godavari district, and is famous for paddy cultivation and aquaculture hub. So if I'll discuss about a few recent episodes which noticed in this year or in the past 1-2 years. In May 2020 this year, a toxic gas leak from the chemical plant killed 11 people, and the hundreds of people were admitted in Vishakhapatnam. And chronic kidney disease is noticed in recent past in many areas of Andhra Pradesh, which is due to probable causes heavy metal and pesticides. And this recently in the initial week of the first week of December, heavy metal poisoning and organochlorine again was the cause of this outbreak. And just after that episode, another short episode was noticed with a high DDT and HCH content in the borewell, which were consumed by the few agriculture or few farmers. So in recent past, we have noticed many such incidents due to chemicals. You can see media has got a lot of attention to it. And amongst the corona virus pandemic, this sudden mystery happened in Eluru town of Andhra Pradesh. So all the aspects were explored by the media as well as by the expert team from the AIMS, Mangalgiri, New Delhi, NIN, NIV, Pune. So all the opinion of all the experts were sought from across the country. So on this outbreak started on the 5th December, and we got the news from our director that we have to send a team. So 6 specialists from AIMS Mangalgiri with a technician started to Eluru, and we reached there on 6th evening, and it was a mass casualty with a convulsion which are sudden in onset, and fainting or a short spell of loss of consciousness was noticed. And most of the people were having no history of seizure or no other neurological conditions in the past. So out of 77 wards, 34 ward secretariat have noticed this episode, and municipality reported around 279 cases till 6th evening, and all were admitted in Eluru District Government General Hospital with one casualty, one death, which was due to respiratory failure. But later it was found that it was probably not related to this episode, but the panic started due to death of one patient. And few serious patients were sent or referred to the Vijayawada Government Hospital, Vijayawada, for better intensive care. So the good thing was that most of the patients were stable, and on 6th evening itself, 77 of the recovered patients were discharged. So in this you can see these were the cases which were admitted on the 5th, and this is the data till evening 6th. So at around 1 a.m. in night, lot of cases were again admitted. So this probably has created a lot of panic among media and among people there. So on 6th, maximum number of cases were reported. And here you can see the time-wise urgency at 1 a.m., 2, 3, 5, 6, 8, 11 a.m., then 12, then 2 p.m. So cases keep coming, and we went there. We took interview of we took the detailed history of patients from the clinicians present there, and then we also examined the patients admitted in the ward, and we have drawn some conclusion that is more males were there in comparison to female, and age-wise also we have seen that it was most of the cases were from 30 to 45, but later it was found that all the ages were affected, and gender wise also it was not significant. Then we plotted the graph of all the cases which were coming. So we have seen it is localized. mm, in some of the pockets it was more, and in other areas out of 34 ward, some were more affected, some were less affected. So we collected oropharyngeal swab to do RT-PCR testing to rule out the um, infectious cause. We collected blood, urine sample, and CSF sample, which were taken to AIIMS Mangalgiri, and water samples were sent to AIIMS New Delhi, and blood and water sample were sent to AIIMS New Delhi. So all biochemical, pathological, and microbiological tests which were done in AIIMS Mangalgiri were found normal. But in blood sample, high lead and nickel content was found. So this was the few images from the media. You can see the panic in GGH Yeluru. So the clue for non-infectious cause we have gathered, and then we focus more towards the heavy metal poisoning, that is lead and nickel, and organochlorine, that is DDT, HCH. So all dengue, chikungunya, Japanese encephalitis were negative, and all 110 patients were non-COVID, were also non-COVID-19. So they were responding to the basic treatment like phenytoin, mannitol, and dexamethasone. So this was a good thing. So there was no need of panic, but now we have to focus more on the control part. So since most of the patients were reported with a single episode of seizure only, and they were responding to the treatment, so we took history from the patients, and they told us that there is a change in the color and taste of water. And other samples which we have sent to Vijayawada and district public health lab were found normal. So we investigated in hospital ward, and then we went to field also, and similar history was noticed in the field also, that on 4th and 5th evening the color was muddy or greenish. So amongst patients, this was a generalized tonic-clonic seizure with a loss of consciousness. So on 6th, our provisional diagnosis was convulsion with unknown etiology, and food or water contamination was suspected. Then once we have received the sample from AIIMS Delhi, then we could conclude that this, due to high level of lead, it was around 2 to 3 times or 4 times more lead was there, and around 400 times nickel, the concentration of nickel was too high, but no clean sign and symptoms of nickel toxicity was present, though lead and organochlorines were noticed high, and the symptoms were also suggestive. And later these lead and organochlorines were found in the food samples also, in the milk sample. So we investigated the municipality water also, and it was found that the municipality water is the only and primary source among the residents, and all patients were from the lower socioeconomic. So those who were using RO water, they were not affected. So we have interviewed many patients there, and we have seen that it was a non-lead leaded pipe. So from the pipe, it was not we were not expecting that, but it was a point source epidemic, and some contamination occurred due to the leakage in the battery, or one of the suspected cause was Nevar, due to heavy rains. The pesticide probably have pooled into the pond from where this municipality supplies the water. So that was one of the doubt. So later, after detailed analysis, we found that the females were more, but these are insignificant, and this is the age-wise distribution of cases. Later, when we projected it in the graph, so a lot of areas were around 26 water tanks are there in the Eluru town, and all were supplied by the same pond, same area of the municipality. So this is the graph of all the cases. So you can see it was maximum on the 6th, and then gradually it declined, and now no more cases are reported from that area. This is the water treatment plant which we observed there. So we have told government to see that whether any dumping yard is there, or the burning of batteries near the pipeline or near the municipality water drainage is there. Then we have focused more towards the organochlorine compounds also, which was found high in food and milk, vegetables, and water source. And another remarkable finding was that when the patient were admitted, there was a difference in the lead content when the patient admitted, and after 24 hours after the patient were again examined. So probably these heavy metals were moved to the bones and bone marrow. So after 24 hours, the concentration was less. So it was a point source outbreak with the possibility of water contamination with lead, nickel, and organochlorine compound. So, thank you.
Thank you so much, sir, for enlightening us. Now, I would like to call our second speaker, Dr. Abhiruchi ma'am, for topic CKD, from detection to equitable access to care. Ma'am, please kindly start your presentation.
Am I audible? Good afternoon, everyone.
Yes, ma'am. Yes, ma'am, you're audible.
I want to share my screen.
Yes, ma'am.
Is the presentation visible?
Not yet, ma'am.
Okay. May I start? Respected chairpersons and my dear delegates, good afternoon. I will be greetings from AIIMS Raipur, and I will be presenting on chronic kidney diseases from detection to equitable access to care. As we all know that chronic kidney diseases are non-communicable diseases of public health importance, and there are many risk factors for the chronic kidney diseases: the diabetes, hypertension, smoker, family history, obesity being the leading causes. And very important aspect is, if the chronic kidney diseases, they remain uncontrolled, and if the affected person survives the complications of CKD, of the disease progresses to end-stage kidney diseases, where life cannot be sustained without dialysis, therapy, or kidney transplantation. The burden of the disease, approximately 850 million people around the world are affected by chronic kidney diseases, and the global prevalence is to the tune of 9.10%. The mortality from chronic kidney diseases and the cardiovascular diseases, deaths attributable to impaired kidney function caused approximately 4.6% of the global deaths in 2017, and it is projected to become the 5th most common cause of years of life lost globally by 2040. So they can affect all people of all ages and races. They are associated with tremendous economic burden, and even in high income countries, they spend typically more than 2 to 3% of their annual healthcare budget on the treatment of end-stage renal diseases. And it affects not only just the patients, but the families as well. An interesting point is that it is crucially missing from the international agenda of global health. It is also absent from the impact indicators for the Sustainable Developmental Goals, and it is also absent from the latest iteration of the United Nations Political Declaration on NCDs, and the global political commitments on NCDs focus largely on 4 main diseases: the cardiovascular disease, cancer, diabetes, chronic respiratory diseases. I will not go into the definition and other details, but a significant point here is we have to be careful to let not the disease progress to G4 or G5. Therein lies the role of prevention and preventive nephrology. And very crucial points in CKD's epidemiology is it is asymptomatic in nature, and screening of CKD, it plays an important role in early detection, and it can be prevented. The progression to end-stage renal disease can be delayed with appropriate access to basic diagnostics and early treatment, including lifestyle modifications and nutritional interventions. But despite this, access to effective and sustainable healthcare provision programs, kidney care remains highly inequitable across the world. Now, it can be detected with 2 simple tests, a blood test and a urine test. And currently, population screening for CKD is not recommended at policy level. The latest recommendations say CKD screening should include only high-risk individuals. So CKD screening coupled with risk stratification and treatment should be implemented in high risk, and this should ideally occur in all primary or community care settings. The principles of primary, secondary, and tertiary prevention apply here also in CKD, and they have shown to be of great value here. Now, why we talk about access to care in chronic kidney diseases? The resources for nephrology care, they remain at critical levels in many parts of the world. There are approximately 1850 trained nephrologists, and they too are unequally distributed, mostly concentrated in urban areas. There is, of course, a problem of brain drain. The Pradhan Mantri National Dialysis Program that provides free dialysis services in public hospitals was launched by Government of India in 2016 only. The hemodialysis in India was started in 1963, in the year 1963, renal transplantation in 71, and peritoneal dialysis as recent as the year 1991. The true burden of end-stage renal diseases in India is not known because of lack of registry, lack of population-based studies. As of now, there are a total number of approximately 5,000 hemodialysis centers in India, which cater to approximately 130,000 patients. And this is able to meet less than half of the demand. The number of patients requiring renal transplant is around to the tune of 2 lakhs, and only about renal, the transplantation performed is approximately 7,500 per year. Unfortunately, a distant third as a modality of renal replacement therapy remains the peritoneal dialysis, which is in fact a good option in rural areas, and only about 8,500 patients are on peritoneal dialysis as of now. So the shortage of nephrologists, late referral of the patients, inadequate health awareness about preventive measures, lack of more cost-effective alternatives like renal transplantation or peritoneal dialysis are important aspects in the provision of care for end-stage renal disease patients. Now, coming on to the barriers to access, first of all, there is lack of awareness of the disease in the healthcare providers and of course in the community. There is a historical practice of CKD being treated in hospitals, often as end-stage renal disease by nephrologists. Lack of CKD-specific prevention, management, education opportunities for healthcare practitioners. Lack of adequate workforce such that the healthcare practitioners are multitasking. The fragmented referral pathways, which are especially to the higher centers of care and to the nephrologists. Inadequate follow-up care, the cross referrals, failure to retain the trained healthcare providers, and mostly they are lost to private sector or moved to other areas despite being trained. Lack of focus on wellness and self-medication and use of informal medicines. This is a very interesting picturizations. You see, the typically central India is lacking in this renal transplantation and the hemodialysis units. So the result of all this is even today, over 90% of the patients requiring renal replacement therapy in India die because of inability to afford care. Even in those who do start RRT, 60% they stop due to financial reasons. And out-of-pocket expenditure can be huge in these patients. Now, increasing the access to everyone, everywhere, can be possible if the CKD prevention is integrated into national NCD programs, and this can bring nephrology care closer to the community. And this CKD advocacy efforts should be aligned with existing initiatives concerning diabetes, hypertension, cardiovascular diseases to have maximum impact. This will result in reduction of renal and cardiovascular risks in general population. Now, to increase access to everyone, everywhere, primary care physicians, nurses, paramedical staff, and other trained professionals should be trained in delivering care, and a management protocol should be provided to the primary care and general physicians. Another modality is use of information technology and e-learning. And of course, the primary care health providers, we can play a key leadership role here. Of course, models can be prepared to address this, the region-specific causes of CKD, increase the quality of diagnostic capabilities, establish referral pathways, provide better assessment of clinical and cost effectiveness. So this is a model to increase access to care for everyone and everywhere. This has been recently provided in a study how to increase the approachability, acceptability, availability, and accommodation, affordability, etc. I will now move on. Just a brief mention about I will, in the study which we had conducted with the state government authorities, Supebera is a small village. It is situated on the border of Chhattisgarh and Odisha. And it was in limelight recently. A number of news clippings were showing this. So we held a number of camps there, and gradually the patients started coming here. We reached out to the community and tried to address their care, and then we prepared drafts, SOPs for screening and management of chronic kidney diseases in Supebera and the surrounding villages. And based on this, we also submitted, we are doing a number of projects, and we had also submitted a community-based research project with Georgian Institute to the state government. And the motto of World Kidney Day was kidney health for everyone, everywhere, from prevention to detection and equitable access to care. This cannot be fulfilled till access to care reaches villages like Supebera. And to conclude, burden of chronic kidney diseases is high. Tool for detection and prevention are available. Care of CKD is still difficult to access. There is an urgent need to increase the awareness of the importance of preventive measures through populations, professionals, and policymakers. Kidney diseases urgently need to be given political attention, priority, and consideration. Primary care workers who are at the forefront of the efforts should be trained for early recognition of CKD. They can act as a bridge between the nephrologist specialist and CKD patients, which will help in improving the quality of life, reduce physical and psychological limitations and complications associated with chronic renal failure, and help patients return to their families, jobs, and social lives. I would like to acknowledge my team here. And this is my team. I would also bring it to the attention of the House that with these efforts, we have also taken baby steps and started with the preventive nephrology clinic, one in kind of initiative at AIIMS Raipur. So that's all from me. Thank you very much for giving me an opportunity. Thank you.
Thank you so much for enlightening us. Now, I would like to call our third speaker, Dr. Umesh Kapil sir. Topic: scientific evidence for inclusion of non-alcoholic liver disease in program of cancer, diabetes, cardiovascular disease. And I request to Dr. Kapil, please share your
screen. I have sent my slides to you. Have you received them? Hello? Hello? Hello, good morning. Yeah. Sorry to ask this question. Are my slides visible? Hello?
Yes, sir, you are visible.
And I am also visible?
Yes, you are also visible, sir.
Good. Thank you very much. I am grateful to the organizers, Dr. Pradeep and all the team, Nandita, Dr. Ankit, and so many people who have providing the backend services for this particular conference. I must admit that must have participated in about 40-50 webinars during last 3-4 months. And this is the only webinar which I am finding it that it is working as per the schedule. The timeline which has been mentioned has been very, very effective. Okay, maybe a delay of 4-5 minutes, which is there. Before I start, I'll just like to make a comment to my dear Dr. Abhiruchi, because Raipur is my alma mater. Okay, I passed out in I am the 1972 batch from Raipur. And I must say that the CKD is an important issue. And recently I was working for the inclusion of non-alcoholic fatty liver disease into the national program for cancer, diabetes, cardiovascular disease, and stroke. So I reviewed the entire this particular program and how we can include CKD into it. Okay, and Abhiruchi, you can talk
Yes.
to me a little later, and
Yes,
I'll
sir,
guide
sure.
you how it can be done. You don't have to do many things at the primary health care level. Only two tests are required, right? One is serum creatinine, and second is urinary albumin.
Yes, sir.
And this can be done. I had detailed discussions with Dr. Sanjay Agarwal, head nephrology, and it can be done. Okay, only we need a good public health specialist with passion to
Yes.
force it. Okay,
Yes, sir.
so
Thank you very much. I'll talk.
yeah. Now I'll tell you the story of inclusion of NAFLD, non-alcoholic fatty liver disease, into the national program NPCDCS. It's a very interesting story, and I was just contributed a little bit. I didn't take entire credit for that, but if you have a passion, if you are scientifically sound, epidemiologically good, and you are able to articulate yourself well, how the things move in the system, I'll just try to tell you. Now, this is if my presentation would be essentially under the following heads: what is NAFLD, magnitude, health consequences, and the consultation at Niti Aayog, consultation at Ministry of Health and Family Welfare, and what's the Government of India future strategy. Mind you, I am honest with that. 40 years at AIMS, I never heard of disease called NAFLD. Okay, it was slightly heard sort of a thing, but never heard in that much detail, which I had joined ILBS, Institute of Liver and Biliary Sciences, and working in the field of liver now. So this is what actually happens. Now, this is a disease which is very common in our country, and there is a deposition of additional amount of fat in the liver. And if a person is not consuming alcohol, which is approximately less than 20 gram, okay, it's if it's taking more than 20 gram, it's considered as a alcoholic liver disease, alcoholic fatty liver. And if it is not, then we call it non-alcoholic fatty liver disease. Now what happens is that when the fat gets deposited in the liver, it leads to steatosis, means fatty liver. As I mentioned, it may be because of alcohol, it may be because of other causes. Now, out of this, about 40 to 50%, the fatty liver gets into the steatohepatitis, means inflammation starts. This, after 10 years or so, cirrhosis starts. And all of you know that cirrhosis do not have any treatment except for the liver transplantation. And it leads to hepatocellular carcinoma. So if you look at the Western world, the NAFLD is one of the most important cause of liver transplantation in all the Western countries. Now, what happens is basically it's not that straightforward that you drink, or you don't drink, you have healthy diet, unhealthy diet, don't exercise, there's a fat in the liver, and it leads to fatty liver, then it leads to NASH, and then cirrhosis. No, sometimes from normal liver to fatty liver to NASH, and NASH back to the normal liver, this cycle continues, right? Only when happens once you have fibrosis or cirrhosis, then it's irreversible. Then the liver cannot be modified. Now, if you look at the prevalence in our country, it is quite high, 8 to 55%. Different studies have been conducted. Our friend at Ballabgarh has conducted study. they found 30%. And if we take the total population of our country at about 1,376 million, adult would be about 816 million. And if we take 20% as suffering from NAFLD, we'll have about 160 million population adults who are suffering from NAFLD. Okay, this is something very interesting. And these are some of the studies which have been conducted. Some of these all studies have been community-based, right? And they have taken the healthy population. Some have taken into the what you call rural area, urban area, and so on and so forth. Now, what happens is, what has been recent, if I had gone into details of the academics of NAFLD, and what we find that the NAFLD is associated with diabetes, obesity, dyslipidemia, high TG level, low HDL level, and now what scientists have been talking about, particularly the hepatologists, that NAFLD is the cause of liver, because of liver, and NAFLD is the mother of all non-communicable diseases. This is something very interesting. And if you look at the deposition of fat in the liver leads to insulin resistance, and insulin resistance leads to different non-communicable diseases, and large amount of scientific evidence is available on this area. Now, what has been seen that strong association, diabetes, NAFLD is associated with diabetes, cardiovascular disease, chronic kidney disease, essential hypertension, peripheral vascular disease, stroke, sleep apnea, colorectal cancer, osteoporosis, psoriasis, and different type of PCOD and so on and so forth. So there's a large number of diseases which NAFLD has been associated, and this is just a figure which talks about the association of NAFLD. Now we have seen about 4,000 cases, and what we find that the hypertension, obesity, and diabetes are common amongst the patients who are attending with the diagnosis of NAFLD. Now what we did, we knew this problem. So what was done? We went to Niti Aayog. Okay, I must say that Dr. Paul is a close friend. He's an Imsonian. I convinced him that this is what it is. And we had an expert group of the Niti Aayog. We invited all the people, DGHs, hepatology, endocrinology, NCDs, everybody we invited them. And then we presented them, Abhiruchi is for you, we presented them a model that how we can diagnose the NAFLD into the primary healthcare system. We cannot treat 160 million in a tertiary care hospital. We have only 529 medical colleges, right? We have a very limited number of gastroenterologists and hepatologists. So we have to develop a system from primary health center, secondary level, and tertiary care level. So we developed this model and presented to them that if you have a 30,000 population, you will have about 12,600 population which would have other causes like HBV, HCV, alcohol consumption, and so forth. So what we require is that we have 428 cases would be high risk with obesity and diabetes, because they are 50% of them have an NAFLD. They can be referred to the CSC, and from there they can be referred to the district level, and then they can be referred to so and so forth, right? Now what we did after we developed an algorithm, and we explained them, okay, this is the algorithm which we need to do it. And we found out the non-interventional blood tests which can be done at the primary healthcare or community health center level. It requires only CBC, and it requires an LFT, which is being done at all the CSCs which under the Indian Public Health Standards. Now, if we can do the LFT and CBC, you can find out what is the FIB-4 score, and what is the NFS score. I will not go into detail of it because the time is limited. Now, after this, what happens that we pushed through, and it was recommended that yes, there is a strong case for inclusion of non-alcoholic fatty liver disease into the national program for control of cancer, diabetes, cardiovascular diseases, and stroke. Now, this is a very large program. It's 9,000 crore rupees. All over this state, all over the country, all the districts have this particular program, a very good infrastructure. And these are the guidelines which have been there. We looked into the guidelines carefully, right? The major focus of NPCDCS is health promotion, awareness generation, promotion of healthy lifestyle, focus on healthy foods, salt reduction, increase in physical activity, avoidance of tobacco and alcohol, reduction in obesity, reduction in stress, reduction in signs of cancer which can be done, regular health checkup. So these are the things which are being done in NPCDCS, and this is what we require for the prevention of NAFLD. So what happens that we went to the ministry and we convinced them. So they constituted a expert group, which was a meeting were held in October 2020. And then subsequently, this Niti Aayog meeting happened in March 2020. We did it in October 2020. And then we subsequently had a meeting with Union Health Minister, Shri Harshvardhan ji, and we requested him that, yes, this is an important disease which leads to liver cirrhosis, which needs the liver transplantation and so on and so forth. And this meeting, we attended the meeting, and this is our director, Dr. S.K. Sareen. This is myself. We had a small group of meeting experts, and we were very open. And then Health Minister accepted our recommendation, yes, that this is possible and we should include NAFLD into the NPCDCS program. Now with this, this is the last slide which I have. Please remember that we were ignorant, okay? Public health specialists in general are ignorant because we are never taught about NAFLD in our undergraduate days, the postgraduate days, right? And we must remember that NAFLD is strongly associated with obesity, diabetes, hypertension, cancers, dyslipidemia, and CKD. Ma'am, you didn't mention about NAFLD in your etiology. Okay, no problem. This is fine because we are not aware about it. We have not gone into it. Now, these prevention and control strategies of NAFLD are similar to what is being practiced in NPCDCS program. And hence what is important is that it should be included, and we are going to launch this particular program maybe with the next 5 years. Thank you very much. I'm grateful again. Thanks a lot. Yeah, I'm through.
Thank you, sir, and thank you all the speakers. I think Ankit is not there, so let me take over the stage and we'll try to wind it up. It was a wonderful session, and I was very privileged to be a part of it. Dr. Rakesh, Dr. Aviruchi, and Umesh sir, you dealt with the topic with such clarity and such ease that it was very easily taken up by the thing. The first thing we started with a neurological illness, the mystery of Eliru fever, and it was finally we reached a conclusion there that the lead and other nickel and organochlorine were the cause of it. That's very nicely put up for Dr. Rakesh. Thank you so much for that clarification. And moving on to Dr. Aviruchi. Dr. Aviruchi, CKD is a part of NPCDCS program. As I just checked with Dr. Swasti, and he told it is not that it is neglected, it is a part of it, and we should try to work together to bring it to the forefront. Your experience in Chhattisgarh was quite good. We are also doing something in Jipmar in and around here. The chronic kidney disease is a problem, and we should try to focus on that. Thank you so much for bringing that to the forefront. And finally, we must learn how a program should be taken to a logical conclusion, as Umesh sir has so nicely put it in front of us. And the passion that is required to take the program to a logical conclusion, we must learn from the NAFLD experience, that how it started and how it was to be programmed, how it is to be positioned, how it is to be projected in the ministry, and how it should be taken to the overall umbrella of NPCDCS. Thank you so much, sir, for all those beautiful learning that you had given us. With that, I just hand over the other part to Dr. Devabrata Roy, my co-chair, and Dr. Manish. So please take it forward from there, sir. Thank you so much. I must thank the organizers for giving me this opportunity. Thank you.
Thank you, Tansu sir, for your words. Thank you so much.
Good afternoon. I first would like to thank the organizers and also the presenters who beautifully presented here. So I'll be very short. Dr. Kakar, who has been like a younger brother to me, and we have been working, together. And he's a very sincere public health enthusiast for that matter. And he has made a very beautiful case of this emerging phenomenon of Ilero-like disease syndromes, which have been simmering for some time. And it's just as well that it has been brought forth, and we have to take guard. And about Dr. Aviruchi, I must say that though CKD as an entity is a corollary to and leading from other NCDs like diabetes, hypertension, etc., you very rightly said that end-stage renal disease syndromes are worthy by, or rather conspicuous as an entity per se. And when we talk about, well, primary healthcare, of course, the principles of primary healthcare has to be adhered to for equitable access and all. And because obviously, it's only at the secondary or tertiary level that people can get and help sort of required at the moment. And then Dr. Umesh Kapil sir, well, he's an exemplary with his credentials in our field. Well, everything is just fine about the way he went about it. Just one thing it occurred to me. I was wondering about the nomenclature of this phenomena called NFLD, non-alcoholic fatty liver disease. Actually, we're talking about, after all, fatty degenerative liver diseases, isn't it? Whether alcoholic or non-alcoholic. Of course, non-alcoholic has been made a point of contention here. Why not just a holistic word like liver diseases? Like we would be able to then say, name this national program as National Program of Cancer, Diabetes, Cardiovascular, and Liver Diseases? Sir, he may observe, please. Otherwise, everything is just fine. Thank you very much.
Sir, in fact, when we look into the non-communicable part, the alcoholic fatty liver disease is the most close to the non-alcoholic part. All others, we only talk about liver. Everybody talks about hepatitis B, C, all viral type of hepatitis. So that takes away we are talking about the non-communicable disease. That's number one. Second is that alcohol is a toxin. And if somebody is consuming alcohol, okay, then he is the one who is responsible for it. While NAFLD is because of the changing epidemiology in our country. Diabetes is increasing, hypertension is increasing, physical activity is decreasing, and that's the one which is leading to non-alcoholic fatty liver disease. And the last but not the least, so alcohol affects only two systems in the body, right, sir? We did talk about liver and possibly a little bit of brain, right? No other organs are being associated with alcoholic fatty liver. But NAFLD is associated with all thought we'll pick up the NAFLD first. It is most easy, and then we can bring in the issue of liver disease program per se. But when we talk about liver disease, the viral hepatitis takes away the majority of it. And then we do have a national de-addiction centers program, de-addiction program for alcohol. So this is the last which I would like to say, and that's the reason. And sir, for your kind information of the group, we have changed the program name also from NPCDCS to put it as a simple national non-communicable disease program. We may bring more diseases into it, okay? Because we have a system in place. We can bring mental health also. And Madam Abhiruchi, CKD has not been got into the program only because you don't have a good public health specialist pursuing this CKD. We have so much of money. Urinary albumin can be done at the primary healthcare level.
Yes.
Serum creatinine requires little bit of equipment. If you do
So,
these two,
yes.
okay, let me complete. So
Yes.
it can be, you can diagnose the CKD at the most peripheral level. And in fact, Dr. Paul asked me if you can do the operational methods, how the CKD and NAFLD both can be diagnosed at the CSC level or PSC level. Okay. I couldn't do it because of this COVID problem. Thank you, ma'am. It's yours. Over to the chairperson.
Chairpersons, if they allow me a minute.
Sir, now there's an open discussion for 15 minutes.
Sir, I would like to bring to your kind notice that what Dr. Kapil sir had just said, we try to implement in around 6 villages adjoining to Supebeda, and we have got excellent results from that. But due to COVID, we couldn't do much more than that. So we're hoping next year we will be in a better luck for that. Thank you very much.
Sure.
Dr. Manish can give his remarks, please.
Dr. Manish.
Good. It is always very interesting and very informative to listening to all of you. And in my career, I am learned a lot by listening to you all. First, Dr. Kakkad has very appropriately highlighted. Let us suppose if we get any unwanted scenario and we want to get we want to explore some epidemics or maybe with some new diseases, how we can move forward. We can start, we can have some hint and we can further explore it. It has been very nicely explained by sir and Dr. Abhiruchi and Dr. Umesh Kapil. Dr. Umesh Kapil, it is very always learning, so much learning from your presentations. And sir has very rightly said how we can address all the issues of which are coming because of, we can say there is an increase in life expectancy and better healthcare infrastructure leading to increase in life expectancy. But more and more NCDs are coming up in lot of different ways. We can say non-alcoholic liver disease, maybe chronic kidney disease, maybe much more presentations which might occur in the future. And you have shown us how to manage and how to sensitize the government and different agencies so that it can be addressed and we can do so much good to the general public and use the public health platforms. So it is very interesting to listening to you, and I pay my sincere regards to all of you, and I thank the organizers for giving us the opportunity to chair the session, which might be a dream for us to chair the sessions for of such a senior teachers, and it is always a very good exercise to listening to you and learning from your thoughts or experiences. So I will always be eager to learn more and more from you, all of you. Thank you, sir, and thank you, organizers.
I just like to make a small comment over here. It is not Dr. Umesh Kapil which made the program successful. Forget about Umesh Kapil. Okay, it is a team. It's a team of 10, 20 people. Okay, and everybody contributes to the team, and ultimately you reach. In public health, single person can never achieve anything. Never. If you think that pulse polio has been eliminated, it's never because of a person. Smallpox, never a person. Neonatal tetanus, never a person. Thank you very much. Thanks a lot. So don't give credit to Dr. Umesh Kapil. I made my part of it. Agreed. That's thank you, sir. Thank you very much.
We appreciate your comments and input, sir. As a team member, we all are working very hard with you. And I hope we are overshooting time. Thank you, everyone. We are moving to the next session. Thank you. I'm pretty straightforward. Thank you. Kind words. Thank you, sir. वहां जाना पड़ेगा ना जल्दी चलो फिर दूसरा सेशन है
A very good afternoon, everyone. Respected chairpersons and eminent speakers and delegates who are here with us on the virtual platform. I, Dr. Shreya Agarwal, the session coordinator. I kindly welcome you all for the plenary session number 9 on COVID-19. I would like to introduce our chairpersons, Professor C.M. Singh Sir, Head Department of Community Medicine, AIIMS Patna, Professor Shivendra Singh Sir, Department of Community Medicine, KGMC Lucknow, Uttar Pradesh, and Dr. Ashu Grover Ma'am, Scientist E, ICMR, New Delhi. I welcome all the chairpersons. Now, I would also like to introduce our eminent key speakers, Dr. Pragya Kumar, Additional Professor, AIIMS Patna, Professor C.M. Pandey Sir, President, IEA, and Dr. Swayam Pragyan Parida Ma'am, Associate Professor, Department of Community Medicine and Family Medicine, AIIMS Bhubaneswar. I welcome you all for this session on COVID-19. A warm welcome, Sir and Ma'am. Now, I would like to request Dr. Pragya Kumar, our first eminent speaker, to start the session with COVID-19 epidemiology. Over to you, ma'am.
Thank you, Shreya. And at the outset, I would like to thank the organizer of Eficon to give me such an opportunity and respected chairperson. With that, this thing, I would like to start my talk. So it is a very general description of the COVID epidemiology. Since the onset of the disease, you must have had a lot of reading about the COVID epidemiology. But just to brief up it again, I would like to present this my talk regarding the brief epidemiology of COVID, then the transmissibility, then what is the current trend of disease in India and in context, especially for Bihar, and what are the community prevalence challenges that is in front of us, and the other challenges which are there. So with this, we all know that the coronavirus, they are the large family of viruses, which constitute the SARS-CoV that was first occurred in 2002, followed by MERS-CoV, that is the Middle East respiratory viruses, this coronavirus COVID-19 disease, and there are 4 other types of coronaviruses which causes common cold. So they are zoonotic in nature, like the SARS-CoV. The majority of infection was in civet cat, followed by this MERS, which was in camel, and this the current pandemic of COVID-19, which is there in the mostly sea fishes or the seafoods. So if we see the transmissibility of this COVID-19, so it basically had got 3 modes of transmission. It transmits, or it gets the susceptible host gets infected with the infected droplet that is more than 5 micrometer in size, which travels to less than 1 meter. Then the second is the aerosol, which we call as a nuclei, which is less than 5 micrometer and it travels to more than 1 meter. And then the contact, so it can occur through the direct contact through our hands or through the indirect contact through the surfaces. So that's why this concept of maintaining a social distancing to at least 1 meter, because in that case, the infected droplet would not travel to more than a meter. And obviously this aerosol, since they are less than 5 micrometer, so they travel more than a meter in the spread of the disease. So we measure the intensity of the spread of infectious disease by its reproduction number, that is the R0. So R0 is the average number of people a sick person will infect. And in case of a coronavirus, this infection rate is 2.5%. So we can see here that for COVID-19, this infection is 2.5. If we reduce the social exposure by 75%, then this infection decreases to 0.625 people. So instead of 2.5 people, 0.625 people will be infected if we reduce the social exposure by 75%. If we reduce this exposure by 50%, then the one person at day 5 will infect 1.25 people, and at day 30, only 15 people will be infected. And if there is no social distancing measure in place, then one person will infect, like we have seen it, the basic reproductive number, that is 2.5 people. And at the end of 30 days, 406 people will be infected. So we can see the impact of, if there is no social distancing, how this disease can spread and how this disease is spreading. So if we see the prevalence, gender-wise prevalence, then it is more prevalent in men than in women. The causes which has been identified is most of the men, they are involved in the behavioral risk factors like smoking or alcohol. They are more involved in the social activities and other key activities and remaining outdoors as compared to women. And women has one extra chromosome more, which protects them from this COVID-19 infection more as compared to men. So if we see the course of the disease following exposure, the onset of first symptom, the mean incubation period is 5.8 days. But usually if we see the clinical visits of the patients, of the clients, they usually visit at the 4.8 days. If the cases are severe and if the death is inevitable, in that case, the death is happening at 15.9 days and recovery usually takes 17.7 days. So if we talk about the disease trends and if we see the case fatality rate, so case fatality rate is highest in UK, followed by France and then Spain. And India ranks the lowest in case fatality, followed by Russia. So here we can see the confirmed total number of confirmed cases and growth rate in top 10 countries. So we can see that the US is highest, followed by India and then Brazil. And if we see the number of growth rate, then we can see here that the growth rate is maximum in France, which is 19.6, whereas in India it is 7.7%. So if we come to the total cases and active cases, if we see the cases in India and Bihar, then we can see that the confirmed cases as of 19 December is 1 crore. And if we see the Bihar situation, then it is 2,46,000, which constitutes 2.3% of the India's affection. If we see the active cases of India, then active cases are right now 3,03,000 approximately. And in Bihar, it is 4,966, which is 1.6% of the total India's active cases. So if we see the recovered and deceased cases in India and Bihar, then we can see that in India, the recovered number of cases are approximately 96 lakhs. And if we see the Bihar, it is 2,40,000. If we see the number of deaths, so it is 1,45,000 in India. And if we see the number of deaths in Bihar, it is only 0.9% of the total deaths of all over India. It is 1,347. So testing, if we compare the India versus Bihar, so in India, we can see that the number of total tests performed were 16 crores approximately. And as of 19 December, the total percentage of tests performed by Bihar is 11%, which is 1 crore 69 lakhs. So the case fatality rate of India, with the effective clinical management and lot of protocol being in place and a lot of ICU being set up. So there was a decrease in case fatality rate. The initial case fatality rate was 3.4%, which dropped down to 2.18% by 31st July. And now the case fatality rate is 1.53%. So if we see the state-wise recovery rate in India, then overall recovery rate for India is 86% approximately. The Dadar and Nagar Haveli and Daman and Diu showed the highest recovery rate of 96.25%, followed by Andaman and then Bihar. The Kerala has got the lowest recovery rate of 66%. And the state-wise trend, if we can see that the first was Maharashtra, followed by second, the Karnataka, Delhi ranked the 7th and Bihar the 11th one. So if we see the proportion of cases in the major Indian cities, so we can see here that the Delhi is showing a shoot up in the number of cases, whereas the Bengaluru, Mumbai and Kolkata, they are going towards a declining trend. So the response of COVID-19 in India, it was a timely recognized problem. All the systems were set in very fast. The International Health Division of NCDC and Ministry also, they have started with the surveillance and response system much before this COVID-19 came into India. There was a rapid ramping up and increase in the number of laboratory capacity by ICMR and by ministry, allowing the private players also to be in place. And this time, during the lockdown, various 4 phases of lockdown, this gave a government and the other system for strengthening of infrastructure and response system. So AIIMS also a designated COVID hospital for this whole period in Bihar. And we have analyzed the data, the approximately 1,800 patients who has been admitted in Patna, this AIIMS Patna. So 74% of the majority of the cases were male, Hindu, and there was only 33% of the cases who showed the contact with the COVID-19 cases and showed with the travel within, gave a travel of within 14 days of the contact. So the age distribution, we can see here that the majority of the cases were from 30 to 45 and 45 to 60 year of age group. And the case fatality, it was also increasing. We can see here that it increasing from 6.67 to 41.57 as the age was increasing. So the symptoms, majority of them presented with the fever and cough and breathlessness. And the number of symptoms, most of them showed a 2 symptoms, presentation with the 2 symptoms followed by 3 symptoms. So the comorbidities, approximately 10 to 11% of them were suffering from hypertension and diabetes mellitus, whereas 3% of them were positive for the chronic kidney disease and the cardiovascular diseases. So the logistic regression analysis, which was done to see the potential factor on the mortality, it shows the adjusted odds ratio of 1.54 with the male. And if we can see the age group, this adjusted odds ratio, it was increasing from 3 to 9 as the age was increasing. And in presence of breathlessness and chronic kidney disease also, it was more. So we can determine this was about the cases in the individual. If we want to see the prevalence of infection at the community level, we need to do a sero survey. So the RT-PCR test and the rapid antigen test, they are the antigen-based tests for the detection of active infection in the individual. So the antibody detection test was utilized for the sero surveys, and a lot of states have done it. Although the data of Bihar, we are not having any data of seroprevalence survey of Bihar, but I have a few data of Delhi. So the Delhi, it showed that the more than 8 districts, they were having a more than 20% of seroprevalence. And nearly after 6 months also, it is only 1/5 of the population which was protected by this COVID-19. Rest 77%, they are still vulnerable, and the containment measure need to be continued with the same rigor. And we can see the number of cases of late, it has been increasing to a many-fold in Delhi. so that the all rigorous measure like the physical distancing and the face mask, hand hygiene, cough etiquette, that should be followed now also. So this is again a data by of the sero prevalence survey of Delhi, and here we can say that the antigen positivity, the IgG positivity in the patients who were influenza-like, suffering from influenza-like illness, that is also 25.46 as compared to the persons who were having no influenza-like symptoms. And in presence of comorbidity also, this was present in 20% of the people, and this was the result of the seroprevalence survey where the people were asymptomatic or symptomatic, but they were not COVID positive. So here we can see that the clients who were COVID positive, they were also 53.37 of the population of those clients out of 208, they were COVID positive, this IgG positive, but 46% is still, this antibody response is absent on those COVID-19 positive patients. So we cannot say that the patient who has been infected once, he is protected enough against the disease. And of late, we are seeing, if we see this trend of the disease reporting, then we can see that the reporting of this influenza-like illness, and because we have seen that there are other 4 viruses of this COVID-19 which causes the cough or the influenza-like illness. So this ILI, we can see that in 2020, there was a very less reporting of ILI due to the seasonal influenza across the country. So the challenges which are in front of us, seeing the winter season and seeing the sort of air pollution, the grave situation of the air pollution, and then we are focusing the disease, other disease, we should focus on the other disease like influenza, which we are seeing that there are less cases being reported. And that's why sustained campaign is still needed for appropriate behavior to prevent this further increase of COVID infection. And that because with the seroprevalence survey, we know that the natural immunity acquired after infection, this needs to be carefully speculated since we don't have any large scientific evidence for the immune response generated by this virus. So we need to carefully see this, and there's no conclusive evidence also that for how long this seropositivity exists, because that follow-up survey, it hasn't been done, so that even if the 53% of the COVID-19 patients who showed up with the positive antibody response, we don't know for how long that antibody response is going to protect those people. So stringent non-pharmacological measure is still that should be applied, and Dr. Swayam Pragya Parida will be talking about the various COVID vaccines. So I'm not going to talk about the COVID vaccine, but the COVID vaccine, they are the next line of protection for us. And I think with the advent of this Covaxin and the AstraZeneca, which are the indigenous vaccine, we may have some hope against this pandemic. So I would like to end my talk with this. Thank you so much.
Thank you very much, ma'am, for enlightening us on COVID-19 epidemiology. Due to some technical issues, Professor C.M. Pandey sir is not able to join us at the moment. I request Dr. Swayam Pragyan Parida ma'am, to Associate Professor, Department of Community Medicine and Family Medicine, AIIMS Bhubaneswar, to kindly enlighten us on update on COVID vaccine. Thank you, Dr. Pragya Kumar. I would request you to kindly stop sharing your screen. Thank you, ma'am.
Sir.
I heartily welcome you, Dr. Swayam Pragyan Parida ma'am.
Thank you very much. My screen is visible?
Yes, ma'am. Your screen is visible and we can hear you very well. Thank you, ma'am, for joining us.
Welcome. At the outset, I thank the organizers for organizing such beautiful event, and respected chairperson, my dear panelists and esteemed delegates. I feel honored to present before this August gathering on update on COVID-19 vaccine. So the outline is two parts. One is COVID-19 vaccine types and how we are going to roll out COVID-19 vaccination process in India. COVID-19 vaccines are of 4 types basically. One is virus vaccine, one is viral vector vaccines, nucleic acid vaccines, and then protein-based vaccine. So the first one is virus vaccine. It is basically, we know, 2 types. One is live weakened virus, and the second one is the inactivated virus. And Covaxin, which is our indigenous vaccine, it comes under the inactivated virus vaccine. Next one is the viral vector vaccine. It is basically a genetically engineered different virus where the COVID-19 gene has been incorporated to deliver into the cell or into the body, and then the immune response is generated. So these are again 2 types. One is replicating viral vector and one is non-replicating viral vector. Replicating meaning it replicates inside our body. So the amount required per dose is less than the non-replicating. The third category is the nucleic acid vaccines, basically DNA and RNA. There are 2 types of vaccine, DNA and RNA vaccine. And the last one is the protein-based vaccine, which is again either subunit vaccine or the virus-like particle vaccine. So basically 4 types of vaccine is being prepared for COVID-19. If you see the global landscape, now around more than 200 candidate vaccines has entered into the clinical stage, and around 58 candidates are in different clinical trials. Around 11 to 12 vaccines are in phase 3 and phase 2 trials. Coming to the Indian landscape, we have basically Covishield, which has been adenovirus vaccine, chimpanzee adenovirus vaccine. It has been prepared by Serum Institute with the AstraZeneca collaboration. And then second vaccine is the Covaxin, which is our indigenous vaccine developed by the Bharat Biotech with collaboration with the India ICMR. And then others are also available. Now these 2 vaccines, Covishield, Covaxin and the Pfizer vaccine, they have applied for the emergency use authorization. Okay. So we have seen a phase 3 report has been out, and we know the many vaccines are safe and many vaccines are efficacious also. Basically the Covaxin, Pfizer, Moderna vaccine, all these vaccines are highly efficacious, beyond 90% efficacy, and the safety data is also available. They are also safe vaccine, but the challenges involved are basically equitable distribution for the needy. As we know, the developed countries, they have kind of booked the doses. I mean, Canada has, purchased kind of around 9 doses of vaccines for the entire population. Similarly, USA, similarly UK, EU, etc., and also India has procured vaccine. Now, the thing is that other countries, poor countries, might not get this vaccine. The needy people might not get the vaccine. This is one challenge. And there is basically mutation of the virus. Also, one different types of virus has been developed out of SARS-CoV-2. So that is also a challenge, whether the vaccine developed will work or not. Now, no data is available regarding the durability of the protection these vaccines provide. There is also lack of safety data on pregnant women and people with comorbidities. That might be issue of cold chain in countries like India because some of the vaccines, they require around -70 centigrade to be stored, like Pfizer. Moderna requires around -20 temperature. That is why the issue of cold chain will be there. And public trust has to be built for the vaccination to prevent vaccine hesitancy. And the last one is, this is the first ever adult vaccination to be launched in India. This might pose a problem. I mean, it should not be, but this is a challenge in fact. Next is how we are going to roll out the COVID-19 vaccination in India. So we have a large experience from the universal immunization program. We have also large scale campaigns. So we know it is possible, but the things we need to handle is cold chain space management, capacity building of the manpower, then the vaccination system planning, how we go for the prioritization registration of the beneficiary, how we go about the AFI management, and at the last, supportive supervision. Universal immunization program is one of the largest public health program in the entire world. The annual, we provide around 2.6 crore newborns and 2.9 crore pregnant women per year. Also provide 12 vaccine preventable 12 vaccines to the children and the pregnant women. Around 29,000 cold chain points are available, and approximately 1.2 crore sessions are planned per year. So this is the biggest program. I can't change my PowerPoint.
Please take your time. You are audible, ma'am. Please take your time. There is no rush, ma'am.
Yeah. So for the vaccine rollout, the NECVAC has been constituted. That is the National Expert Group on Vaccine Administration for COVID-19, and where the member Niti Aayog is the chair, and then Secretary Health and Family Welfare Department is the co-chair, and their representation from the relevant ministries and 5 state governments and other technical experts are there. Now, the governance mechanism also has been developed from national level to the state level to the district level, and at the end up to the block level. So there is a state steering committees, there are task force, and then control rooms in state level, district level, and also up to the block level. Now this NECVAC provides guidance on prioritization of population groups, vaccine selection, procurement and inventory management, and then vaccine delivery. So let us first see the prioritization of the population. Now in phase 1, approximately 30 crore population will be given. And who are the priority people? Number 1 is the healthcare workers, around approximately 1 crore, frontline workers 2 crores, and then the people beyond 50 years of age and less than 50 years with comorbid conditions. And in healthcare workers also, the different groups are frontline healthcare workers and ICDS workers, and then ANM, SASA, etc., nurses, medical officers, paramedical staff, lab technician and other technicians, pharmacists, support staff, ambulance driver, etc., and then the students. They will be the priority groups under the health worker categories. Now, who are the frontline workers? The other priority group is the frontline workers, which include central police forces, state police forces, home guards, civil defense volunteers, municipal workers, etc. So after this, the prioritization of the beneficiary groups, next is the vaccine selection. Now, for vaccine selection, this has been seen, majority of the vaccines or the vaccines which has gone into phase 3 trials, they follow 2-dose schedule, maybe 21 days apart or 28 days apart, but basically they follow 2-dose schedule. And vaccines are developed using multiple platform because the part is that a beneficiary should be given the same type of vaccine, and the vaccine is not interchangeable. Okay, so from the multiple platforms, the vaccine has to be procured. And the storage temperature for most of the candidate vaccines has been seen as per the UIP vaccine, that is 2 to 8 degrees centigrade. And what are the specifications of the COVID vaccines which is going to be rolled out in India? Basically liquid vaccines, and it has to be given most probably through IM route, but can be given subcutaneous. Doses per beneficiary will be 0.5 ml per beneficiary if it is IM route, and the vial will be multi-dose vial, and the cold chain space required will be 4.6 ml approximately. Coming to the next part is the inventory management. In inventory management, we have three components. One is the cold chain space management. One is the vaccine management. So coming to the cold chain space management, if you see the UIP vaccine, volume per beneficiary is around, one beneficiary gets around 11 to 12 number of vaccines, and per beneficiary around 93.5 ml of storage space is required. Okay, and if with that, COVID vaccine per dose is required around 4.6 ml of cold space, and if you add the 10% wastage rate, it will be around 5.1 ml per dose. And if you require 2 doses, there will be 10.2 ml of additional cold chain space. So we need to think about it. So if we require, supposedly if you require 4.6 ml or 5.1 ml per dose, then 1 liter of cold chain space will keep around 217 doses of vaccine. So similarly, the vaccine cold chain space has to be seen. And we know the different models are having different storage capacity. And the third factor need to be kept in mind is the number of people need to be vaccinated. So according to the number of people need to be vaccinated and number of doses to be given, and the capacity, cold chain space capacity, training, and then the additional ILR and other cold chain equipments need to be procured. Not just ILR, the point where, outer sites, cold boxes, and then the vaccine carriers should be calculated based upon the population size. Okay. After the cold chain, one more requirement is the vaccine estimation. So vaccine estimation is based upon the population of the relevant the catchment area, percentage of population to be covered, number of doses to be given, wastage multiplication factors, and over how many months the campaign will be going on. So first is cold chain space has to be calculated, and additional cold chain space needs to be procured, vaccine has to be procured, and the next one is the AD series has to be also procured. So number of doses of AD series equal to the number of doses required. And the last one is the AFI, for the immunization waste management, number of hub cutters, the bag polythenes, like red color polythene, and then the black color polythene, and other immunization waste appropriately has to be managed. Next one is the vaccine delivery and tracking mechanism. We had already electronic vaccine intelligence network, that is the EVIN, which actually goes for real-time tracking of vaccines, and also it manages the or monitors the cold chain. It is available nationwide. It has been upgraded with the CoVIN, that is the COVID Vaccine Intelligence Network, which has been developed or designed in coordination with the IIT Delhi. This is required for monitoring of the COVID vaccine delivery to the prioritized category of the population. Now, EVIN is Electronic Vaccine Intelligence Network, is basically it provides real-time stock visibility, and it also goes for the temperature monitoring. Now, CoVIN will also provide help in beneficiary registration to session allocation up to beneficiary vaccination, and also it will include AFI reporting, etc. So these are the two apps that will help in rolling out the COVID-19 vaccines. Now, COVID will help not only administrator at the national level, it will help in beneficiary registration. It will go up to the vaccination point, up to the vaccination. So we can find out what is the coverage of vaccine, who have been given vaccine, and whether there is an AFI happening or not. So everything will be known through the COVID mechanism. So coming to the operational planning for the COVID-19 vaccination, we have first one is vaccination session planning, and then the second one is a registration of beneficiary. The first one is identification of the session. This has to be pre-identified by the district administrators, and the session site has been identified depending upon the different priority groups. For healthcare workers, so it will be given in the government health facility at PSC level and above, and also in the private healthcare facility where there is more than 100 healthcare workers are available. For the frontline workers like the army and the police personnel, it will be given in the health facility and also in the offices, schools, and community halls, etc. For the prioritized age group like more than 60 years and more than 50 years with the more than 50 years and less than 50 years with the comorbidities, they will go for the health facilities and other outreach sessions like schools and community health hall, etc. Now, how to set up a vaccination site? It has been clearly given in the operational guideline. There will be separate entry point, separate exit point. There will be, proper ventilation. There will be 3 rooms like waiting room and then the observation room, etc. The waiting room will be first. They will the facility for hand washing and sanitation will be there. Next one will be the vaccination room where the logistic will be available. The vaccinator will be there, and then the vaccination will be given. And the last one is the observation room where the person will be observed for 30 minutes for to see whether there is any AFI happening or not. So appropriate social distancing facility has to be maintained in all these 3 rooms. Now, who will be the vaccination person or vaccination teams? Vaccination teams basically consist of 5 persons. One is a vaccinator who will vaccinate, and other are the support staff. So the vaccinator officer is the trained who gives the injections, and then the other persons will be who checks the registration status of the beneficiary, and then the other person will verify the document, and the other 2 persons will support, basically support staff, like they will go for crowd management and ensure the observation of vaccinee for 30 minutes. So if the session load is beyond 200, additional team will be required. Now, next one is the registration of beneficiary. This is going to happen through CoWIN app. So the person can go for self-registration, or bulk registration can happen if in case of an office like where frontline workers are there. So from that organization, bulk registration can happen also. So the pre-registered beneficiaries will only be vaccinated and rest will not be vaccinated. And the CoWIN will incorporate the unique health ID. It will be incorporated. Safe VAC will be incorporated there also. So using this CoWIN app, not only the beneficiaries will be registered, self-register themselves. There will be session planning. The beneficiaries will be given SMS. Where is the vaccination site? When they will come for the vaccination. So after vaccination, then the SMS will be sent, and then the vaccination certificate will be given after completion of the vaccination. So after beneficiary is vaccinated, SMS will go, and then it will also tell in the SMS there will be when is the next vaccination, and then at the end of second dose there will be certification. So apart from that, there will be AFI surveillance through CoWIN SafeVac, and supportive supervision, and of course, communication and social mobilization. Communication and social mobilization is a must to gain the public trust. Here, media can be engaged, social media can be incorporated, and community can be mobilized. So at the end, we have developed a safe and efficacious vaccine in a very short time. Operational guidelines has been prepared, a NEGVAC committee has been constituted, and also we have UIP in place, which is the biggest program. We know, I mean, what are the possible challenges we'll face, and we hope this is the first adult vaccination program will be very much successful in India and in all over the world. Thank you very much.
Thank you very much, Dr. Swam Pragyan Parida ma'am. It was a much informative session we have with you on update on COVID vaccine. Now the session is open for discussion. I request the honorable panelists to kindly start their video and unmute themselves. We can have the discussion for 15 minutes.
Yeah, thank you, Dr. Shreya Agarwal, for coordinating this session. And I think that Professor C.M. Pandey, sir, who also hails from Lucknow, could not join because of certain technical reasons. This session was planned for three beautiful lectures, but only two could have been taken up. The first was COVID-19 epidemiology by Dr. Pragya Kumar, who is additional professor at AIIMS Patna. And she has very elaborately explained about the epidemiology of the COVID-19. Thank you, Dr. Pragya. And Dr. Swam Pragya, Dr. Swam Pragya from AIIMS Bhubaneswar has updated on COVID-19 vaccine very beautifully. And the most important part is that we have learned a lot about the COVID-19 vaccines. But how this COVID-19 vaccine will be given to our masses or public to curb this menace of this pandemic, that has been elaborately and very beautifully explained by Dr. Swam Pragya. So we are very thankful to both of the speakers who have spoken. Thank you very much. Dr. CM Singh, do you want to say anything? He is a very good friend of mine. Yeah.
Good afternoon, everyone. Sir, you rightly told both the speakers explained very well about epidemiology by Dr. Pragya and vaccination, the preparation for vaccine, required preparation for vaccination and development of vaccine by Dr. Parida. I congratulate both of them for delivering a very nice lecture. In vaccination trial, I can say we are conducting co-vaccine trial and we are at phase 3. We are facing challenges regarding recruitment of participants in trials due to a lot of misconception regarding vaccine, which is going on WhatsApp group, different WhatsApp groups. So issues are there, as Dr. Parida told, what about the antibody, till when it will persist? These are the questions in minds of people, and these questions will be answered by time only. So we have to follow and we have to see how it's going on. So challenges are there. We know it's a new vaccine. Challenges are there, but as I think, particularly for COVID vaccine, co-vaccine, it's going well. There are not a lot of safety issue, only some local symptom like pain at the site of injection, fever in some very less cases. It has been reported, but there is no serious adverse event till now. So vaccine trials are going well. Hope for the best. Thank you. Thank you again. I think Dr. Asu would like to say something. Dr. Asu.
Hello, good afternoon, everyone. Am I audible?
Yeah, you are audible.
Yes, ma'am, you are audible.
Okay. So I think I really must congratulate the organizers to keep this one of the very, very important session for this Eficon. And I think this is the one session which should have been attended by most of the delegates. But I don't know, the organizers can tell that who are all the delegates, whether it is being benefited to them or not. Because in these two talks by Dr. Pragya and Dr. Parida, I think other than chairing the session, I would have been one of the, I attended it as one of the delegates, right? So I learned a lot because some of the things you don't know that what is happening outside your area of work. Right. So congratulations to Pragya and Parida, both of you. And both of you have done an excellent efforts to gather the entire information from the literature or from your own studies and from other sources, which I think I'm not aware of. But even some of the issues which were not there even at ICMR also, you have very well articulated, and especially from Dr. Pragya when she talked about that protection of this COVID-19 virus, especially among females due to extra X chromosomes, that, you know, those are some additional information. And from Dr. Parida, when you talk about the cold chain management, the delivery points and all that, those systems which are in place. And I don't think so that it is going to be a challenge for our country because our UIP program is very well in place. And we regularly attend the meetings of the PIB where they talk about the procurement part, the logistics part, and the delivery part of the COVID-19 vaccine as and when it is coming up. So both of you really deserve a congratulation from my part, and I think others as well. And I think one suggestion to the organizers, if they can share these presentations in a form of Google link or something like that to the delegates, and as and when they can access to this information, would be quite useful to other parts who have not attended this meeting. And these two areas really open up an area of research as well. For example, in epidemiology, other than that, we can talk about the COVID-19 after effects, and those especially among those who have been affected by COVID-19 and those who are the frontline workers. So various research areas have been opening up, like stress among those, or the stress among the caregivers, and stress among the frontline workers, or some other comorbidity conditions should also have been, those upcoming areas for the researchers and the academicians. So thank you. Thanks to Dr. Shwinder and Dr. CM Singh as well, and to the speakers as well. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you all.
Thank you, ma'am. We will be putting forward your suggestions regarding the sharing of presentations.
Yeah, not only these presentations, these two presentations, but all the plenary session presentations, if they can be shared with the delegates and the participants, that will be useful for us in future training and teaching experiences, and for going for new researches also. That Dr. Ashu has aptly said that we should get these all these presentations. And I think that the organizers will be very happy to share all these presentations. So in the last, I would like to thank Professor Vikesh Srivastava, who has been my mentor at KGMU Lucknow and has organized such a wonderful event in this COVID time. Although I was also supposed to reach to Rishikesh, but because of this COVID-19 problem, I refused to go there, and I am attending this meeting online. So thank you, sir, Professor Vikesh Srivastava, sir. You have been always there to support us and for organizing such great events in the past, as well as we hope that you will be organizing these type of events in the future also. Thank you, sir. Thank you very much, sir.
Thank you very much.
Thank you.
Thank you. Thank you.
Thank you.
Thank you so much to all the honored, dignified chairpersons and eminent speakers who are with us here for this session. It was a very much informative session, and I would like to express my sincere thanks to all the chairpersons and eminent speakers for sparing their much valuable time with us and for your support you have so generously given to us. And I would like to take this opportunity on behalf of AIMS Rishikesh and Team Eficon 2020 that we will be looking forward to have you with us in our future sessions whenever we can plan that. Thank you very much. Thank you.
I think I would like to say my regards to Dr. V.K. Srivastav. I can see him live on the plenary hall. Good afternoon, sir. How are you? Very, very well organized conference, sir. And thanks for remembering us, right? And I hope this organization and this body goes a long way and contributes to various national health level decisions and policies to the country, sir. And we want it to grow and grow under your leadership, sir.
So our next conference will be in Jodhpur, AIMS. AIMS Jodhpur. That is our next venue. Maybe sometime.
Very good, sir. Good, good. Congratulations to you, sir. Really, my heart felt.
Yeah. Thank you, sir, because of all your participation. We are able to make it. Yeah.
Right, sir.
You know, Dr. CM Singh, Dr. SK Singh, all these, they are part of our governing council, but we are missing them. Anyhow, we had a meeting and we will be circulating it and for your comments. Yeah. Our president EFI, Dr. Umesh Kapil. Yeah.
Thank you, sir. We could not attend meeting yesterday, and we will be definitely going through the minutes. Thank you very much, sir.
Thank you, sir.
Thanks. Thanks to our DHS.
Good afternoon, sir.
Good afternoon, sir. Rakesh Srivastav, sir. And Dr. Umesh Kapil, sir. Good afternoon, sir.
Dr. Srivastav, I could not recognize you, sir. You were wearing mask.
मैंने तो इसीलिए कहा सर थोड़ा हटा लीजिए इसको।
See you, sir. तभी आपने उनको मास्क उतारने के लिए बोला।
हमने कहा आशु पहचान नहीं रही है, जरा रक्षा थोड़ा दिखा दीजिए।
आशु कैसे नहीं पहचानेगी, सर? Sir, good afternoon, sir. And to Dr. Kapil as well, sir.
Good afternoon, how are you?
मैं ठीक हूँ, sir. मैं बिल्कुल ठीक हूँ। We are there to seek your blessings.
Blessings are always with you.
I know, sir. I know. I can see Dr. Oh, thank you. We need to go to a longer journey, sir. Now, I was thinking when you were there, we did not have a session on HTA. We should have one session in this EFI. Maybe we can plan next in AIMS Jodhpur.
Yes, yes. Sure. As a session even before Jodhpur, because things are moving very fast as far as HTA is concerned. And before you go for next conference, you will find that the structure is totally consolidated about introduction of HTA in the national programs.
Yes. That is much needed, sir, because the pace it is going on and with support of all of you good leaders, probably it will have its own path and will contribute, because this is a very much upcoming area for at least our country when we have a resource crunch is concerned.
In the last meeting under the Secretary Health and Family Welfare with all the joint secretaries who are leading the program and MD, NHM and state MD and HM, it was decided that every new introduction of intervention, which is technology based, will have to clear HTA test.
Yes.
So once it is decided, it means your annual load on drugs, diagnostic, which are coming in,
Devices.
and the newer technology has to be there in the HTA cell, which comprises of 7%.
Yes.
Will not be able to take the load.
Very true, sir.
Either you build up your capacities or they will outsource it. And when they will outsource it, then total ICMR will become defunct as far as HTA is concerned.
ऐसा मत होने देना सर.
मेरे हाथ में थोड़ी आप लोगों के हाथ में.
No, sir, I think it will have its own pathway, and we really have to appreciate the efforts which already have been taken care in the past under your leadership. We want to make you as one of the champions for HT in the country, sir. That's my dream, sir. We can think
आप
of.
अपने डीजी साहब से बात करिए, क्लिनिकल पाथवे बन गए हैं.
हाँ हाँ.
बन गए हैं. Now the next thing is that these pathways should be integrated within the ICA.
Within the ICA and within the national programs, sir. Within the national
थोड़ा आपको
program.
लेना पड़ेगा ना लीडरशिप, आप ही के डिवीजन का है सब.
बिल्कुल बिल्कुल सर, लेंगे सर.
चलिए.
Dr. Kapil sir, good afternoon, sir. It was a very excellent talk to hear you, sir, on NAFLD.
Yeah. Thank you, ma'am. When we are concluding for the validity, we request you all to join soon for the validity function. Thank you, everyone.
Okay, thank you. Thank you, sir. Thank you, everyone.
Audio. Good afternoon. Good afternoon, all the participants and the distinguished members of the Epidemiology Foundation of India. I would be delivering the oration on behalf of Professor Ravikant, Sir, Director and CEO of All India Institute of Medical Sciences, Rishikesh. The topic of the oration is evidence-based public health. So we all are aware what is an evidence-based evidence, which is often defined as the available body of facts or information indicating whether a belief or proposition is true or valid. So this definition was given in 2001, which was often considered in the evidence-based medicine. And these are the mainstays of evidence-based medicine, which is in a pyramidal format. The apex of the pyramid are systematic reviews and meta-analysis of randomized controlled trial, whereas editorials or expert opinion forms the base of the pyramid. And the same thing has been endorsed by most of the research organization and academia worldwide. And it is very clearly evident in the logo of Cochrane. So Cochrane-based evidence has all the details related to the evidence-based medicine. This also gives us an idea about the risk of bias which would be there in a study. So as we move towards the apex of the pyramid, the risk of bias gradually reduces and the quality of evidence increases. So this is a very good pictorial explanation for evidence-based medicine. Now we come to WHO grade system. So grade is basically recommendation, assessment, development, and evaluation. So grading of recommendations, assessment, development, and evaluation system for to be done by the authors to very clearly mention what is the grade of evidence in a particular randomized control trial. So these holds very much paramount importance to randomized control trials to develop recommendations based for the usage in the daily practices, including public health issues. Now we have moved gradually from evidence-based medicine to evidence-based public health. So this is a paramount shift in the emphasis from randomized controlled trials to the more relevant evidences when assessing the public health issues. So if we go by the history of evidence-based public health, in 1997, Janik has published a review wherein he has very clearly mentioned that there are links between evidence-based medicine and evidence-based public health. And he has very clearly noted that the foundation of both evidence-based medicine and evidence-based public health is epidemiology, which are often parallel with the evidence-based medicine. And it has got a unique challenge wherein due to the complex and interventions and involvement with multiple communities and societal issues, evidence-based public health holds a different virtue compared to evidence-based medicine. So what do we mean by evidence-based public health? It is defined as the conscientious, explicit, and judicious use of the current best evidences in making decisions about the care of communities and population in the domain of health protection, disease prevention, health maintenance, and improvement, which includes health promotion. The definition is given in the Janik's epidemiology. So the process of developing evidence-based public health starts with community assessment. Then to identify, we often see in terms of research or research problems. So it is here, it would be quantifying the issues in a community, then developing a concise statement of the issues in the community,
followed by determining what is known using scientific literature, leading to developing and prioritizing programs and policy options, which would further lead to developing action plans and implementing those interventions in the community, and then finally evaluating the outcome of those interventions in the form of policy or program. So this is a full circle of developing evidence-based public health. So there are certain domains which are involved in developing the evidence-based public health. So these are, they are blended together, and the major four are there, like they are best available research evidence should be available in the public domain first, and that has to have a very robust methodology and should have been, the data should have been accessed to the researchers. Then there should have been very clear understanding of the population characteristics on which the interventions are applied, the need, values, and preferences of those population, and the resources which would be utilized for application of the intervention, including the practitioner expertise. So all these three basic areas, when they blend together, that helps in decision making. Now coming to the different forms of evidence. Now if you could see here, as we move upwards, the level of evidence gradually increases and it becomes more of objective in nature. Whereas at the bottom, it is more of subjective in nature. So personal experiences, word of mouth, without any particular documented evidence, are more subjective in nature, has low grade of evidence, whereas scientific literature, public health surveillance, and evaluation of the various health programs, they are more objective in nature, and that is they are considered to have robust level of evidence. Coming to barriers of evidence-based public health, certain barriers are there, which would be lack of leadership in setting a clear and focused agenda for evidence-based approaches. There is again a lack of view of the long-term horizon for program implementation evaluation. External pressures would be there in a community, which would be a very big barrier to develop and implement processes for implementation. Inadequate training of the key public health disciplines is another barrier identified in the literature. Then there are lack of time to gather information, to analyze data, and to review the literature for evidence is often a barrier, because a lot of time the data or the information may not be available in public domain. Third, and the most important, would be lack of comprehensive up-to-date information on the effectiveness of programs and policies, which would give an idea about overall and high-risk population. Should have been, it often is a very big barrier for developing evidence-based public health. Now, the process of evidence-based public health will begin with engaging all the key stakeholders, which includes all the like political leaders, the community members, the population residing in that area, the community leaders, decision makers. So those engaging these key stakeholders is the first step in developing the public health evidence process. Second would be finding the information and the resources available in the community and from the literature. So which would be need assessment of the community by doing certain surveys or doing interventions in the key decision makers, finding in evidences from the literature about the similar risk or similar problems in the community, and certain academical theoretical theories would be there. So these frameworks would be the next step is developing evidence-based public health. Next step in developing the process of evidence-based public health would be developing programs which are based on assessment. Now, this assessment, as we have said in the first part, after engaging stakeholders and assessing the local needs and demand of the community, that these two should guide for developing the program on based on assessment. Finally, once the interventions are done, then there should have been evaluating processes which are very robust, which are not easily jeopardized by the involvement of the key holders. So these evaluating processes should give us a very clear idea what is the impact of the public health interventions, and then what are the outcomes of these interventions in the community settings. Finally, learning from our work and sharing it in the ways that are accessible to all the stakeholders would be a very guiding principle for such future interventions in the similar communities. With this, I thank you all for listening to me patiently. Thank you very much.
स्टॉप कर देना।
आप लोग बोले आप जो एपिडेमियोलॉजिकल एसोसिएशन के इंचार्ज तो
आपके सारे क्वेश्चन म्यूट कर, आपके सारे क्वेश्चन म्यूट कर।
इधर पिक्चर लो।
Professor R.K. Srivastava, chief guest to this military function. Professor Veena Ravi, organizing secretary for the event. Professor C.M. Pandey, vice president, Epidemiology Public Health Association Foundation. Professor Ajit Sahay, former professor, director professor, Biostatistics, JIPMER, Pondicherry. So we started this conference. In fact, we started pre-conference on 18, followed by we had inauguration on 19, and today is the last day. This was attended mainly, it's a hybrid system that we adopted, just keeping in with the COVID epidemic. So majority of our participants, they attended online, and there are a lot of sessions covering different fields. So, and particularly our MPH students, they played a very vital role, and each of them, they're coordinated to different sessions, and they conducted very well. And all our many chairpersons of the sessions, they also participated from different, right from ICMR to different universities, from north to south, all of them participated. One thing, this was our first annual conference of Epidemiology Foundation of India, and at least I am very happy being secretary of the association. I am really delighted to see that we have started on a big tone, you can say, and hopefully this will continue. Sir, with your presence to this conference, really it has added color to the event, particularly in the situation where people are, afraid of moving out. Dr. Veena Ravi has taken a lot of pains in making this event memorable. Dr. Ravi Khan, the director and CEO of AIIMS Rishikesh, he is busy in elsewhere, so he could not make it. But he has been, overseeing everything right from the beginning to make this event memorable. Dr. C.M. Pandey has been working for this in the different sessions, and also we have received his help time to time, and we have been discussing on the Governing Council also how to make it a memorable one. Professor Ajit Sahay is always available for any event. Recently in Lucknow we had a workshop, and again he was our resource person, and he has been helping a lot. In fact, we have been planning a number of forthcoming things that we will be using it and to make the second conference more memorable. Dr. Pradeep Agarwal has been the real force behind the whole event. Of course, under the patronage of Professor Ravi Kant and Professor Veena Ravi. Dr. Vartika Saxena, who is the head of department, she has been, conveying me the preparations of conference and how things are moving. She is my MD student from Lucknow. So she has a special regard for us. So she had spread all the resources from the department to make this event successful. Lastly, I think, the media group, which was, just making this event happen on different channels, they also deserve, because we tried. In Lucknow, we tried to use our own system. We're probably having a system where they can handle it, they are professional. That was something good, so that we can handle that are parallel sessions and the quality display. So with these 2 words, I again thank everybody on behalf of Epidemiology Foundation of India, making this event happen and making it memorable. Thank you.
No, sir, may I request Professor Umesh Kapil, sir, to give the concluding remarks? Sir will be joining us shortly.
In the meantime, I request our organizing secretary, Professor Veena, to say 2 words before I request the chief guest.
Sir. Dr. Sahai, Dr. Pandey, thank you so much for putting your faith in us in Institute, which is a very small institution by all standards, to organize the National Conference of Epidemiological Foundation of India. I'm really happy that it has gone very well, and the participants were in large numbers, very large. Everyone was surprised when we told them that so many are participating. 130 around, they are presenting their work here in this conference. It's been a very good experience, at least in our discipline, in my discipline, and extended help from for Dr. Umesh Kapil. Is he online?
Kapil, sir.
थोड़ा सा
Hello, good afternoon.
Yes, Dr. Kapil. Hello. Yes, Dr. Kapil. We are in the voluntary session.
Well,
we are eagerly waiting to listen to you.
Thank you very much, Dr. V.K. Srivastava, sir. Hello.
Sir, we are here. I hope some internet connection problem is there.
No, it's fine. It's fine. I am most grateful to organizing committee for
Just
giving
make
me this
180
opportunity.
degree rotation. 180 degree rotation.
Is it okay?
Perfect.
Okay.
Perfect.
Sorry.
Go ahead, sir. You are on.
Good afternoon. I am most grateful to organizing committee for giving me this opportunity to participate in the valedictory function. First, I would like to pay my most sincere respect and thanks to Dr. R.K. Srivastava, who has been our mentor and guiding force in all our academic activities. Sir, if you recall, in 2004, we had a conference in All India Institute of Medical Sciences, and you were delivering the keynote address. And at that time, the additional secretary congratulated you on becoming the DGHS. I can't forget that day. So, sir, we are always grateful to you for our guiding us. And secondly, I would like to thank Director Rishikesh for giving us this opportunity. Eficon 2020, the Epidemiology Foundation of India will always remain grateful to Director AIMS Rishikesh for giving us the all support facilities and infrastructure facilities for organizing this conference. We are also grateful to Dr. Vartika Saxena and Dr. Pradeep for leading the entire team of EFI members who are there, and the new members who, like, from particularly from the College of Community Medicine, Masters in Public Health, who most passionately and dedicatedly they worked right from the morning 6 o'clock to 11 o'clock at night for helping in a successful organization. My most sincere thanks to all the speakers, chairpersons, and after all, the participants from different parts of the country, including and from Sri Lanka, from other countries, neighboring countries who participated in it. Once again, my most sincere thanks. And Dr. Srivastava, again, most grateful to you. Thank you very much, sir.
From Team Eficon, we are wishing you a very happy birthday, sir.
Oh, thank you very much, sir. Thank you. So nice of you, sir. Thank you very much.
Thank you.
Thank you, everyone.
Actually, the program is finished once the president has given the concluding remarks, but as per your request, I want to say a few words. This is very much needed in India, that a foundation like this should take lead in all the public health programs as a partner with the government, as a partner with medical colleges, as a partner with various type of public health institutions which are creating human resource for it, as a partner with research organizations who are working day and night and trying to create a robust structure of product to be integrated into the public health program. And leaders like Umesh Kapil, Dr. V.K. Srivastava, support from various heads of the Apex organization like AIMS Rishikesh, KGMU, AIMS Delhi, and even I think the institute where Kapil is working, ILPS. Now, these type of supports do not come without having some credibility to the organization. We have been able to get these type of supports. 400 plus participants over there in the conference, the first conference, and that too in the period of COVID, itself is a reflection on the acceptability of the work which you have started through this foundation. So my best wishes, good luck. Let us see more and more of you in future as a partner in various government initiatives, institute initiative, and research initiative. My best wishes. Thank you very much. Okay, sir. Thank you.
सर आप लोग हमारे स्टडी के असिस्टेंट प्रोफेसर हैं प्रतीक सर, ये दौड़ भाग का काम नहीं रहेगा।
We would like to give a clap for MPH students from there to the
हम लोग बैठे हैं आपके पीछे करा देते
डिस्टेंसिंग खत्म कर दी।
How many MPH यहाँ पे हैं? हमने तो 5 ही जाने थे, आप लोग 7 आ गए। Thank you very much.
7 student है।
They belong to some of you from different NGOs. बहुत सारे
India from all streams.
all
Physiotherapist, dentist,
हमको तुम भी आ जाओ इधर।
Thank you. Go to job market का सर। How is the job market?